Ma'am, we are going live in 3, 2, 1. We are live now.
Dr. Vishal?
Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all for this Symbiosis Series, Webinar 2, on the topic Everything About RPL. This webinar, Symbiosis Series, is between the Foxy Endocrinology Committee, the Bhopal Opposite Gynec Society, and the Bhopal Menopause Society. I would like to introduce the co-convener of this Symbiosis Series webinar, Dr. Monica Singh. She is Professor at LN Medical College, Bhopal. She is Honorary Secretary, MP Chapter ISAR. She is Vice President of Bhopal Offset Gynec Society and Bhopal Menopause Society. She had successfully organized 27th Annual ISAR Conference 2023 at Bhopal. She is convener of Perfection Series and founder and convener of this Symbiosis Series.
Thank you.
Over
Thank
to
you
you,
so
madam.
much. Thank you so much, Dr. Vishal. I extend a very warm welcome to the office bearers of Bhopal Obstetrics and Gynae Society, Bhopal Menopause Society, because of whom we got an opportunity to have an alliance with Foxy Endocrinology Committee, and we did a symbiosis. Symbiosis is basically a biology term. It means how a relationship between two living things is mutually beneficial to both of them. So this is webinar 2 of Symbiosis series. The first webinar we did with Foxy Perinatology Committee, Chairperson Dr. Chinmay Ratha ma'am. And this time Dr. Rakhi Singh ma'am was very, very kind to give us permission to do a series with her. So this is all about RPL, or all about recurrent pregnancy losses, also known as recurrent miscarriages. The purpose of designing and executing this particular webinar is that we get some guidelines on the investigation and care, which are current evidence in the management of RPL. We know pregnancy loss means all these pregnancy losses right from the period of conception up to 24 weeks of gestation. Just as an introduction, these pregnancy losses can be sporadic or they could be recurrent. Now, sporadic losses are usually first trimester losses, and usually they are associated with chromosomal abnormalities or aneuploidies in the embryo. So, usually they do not recur. It is the problem when there is a recurrent pregnancy loss or a recurrent miscarriage. The guidelines, because our speakers are so many, they will tell you whether you should consider a recurrent miscarriage when there are 2 or more losses or 3 or more losses. But conventionally, the guidelines go by 3 or more losses. Now, Lancet very recently has come up with a series of 3 articles. Lancet is a very well read journal, and they have, criticized this approach. They want the fragmented approach to be, done away with. They want that a stepwise graded approach should be done in the management of recurrent miscarriages. Whenever there is a first miscarriage, first of all, you have to take that woman into your confidence, counsel her properly, and give her the necessary support and counseling, so that the second pregnancy, when she undergoes, she might not be a terrified patient as to what will happen. But if unluckily the second miscarriage happens, that is the time you have to take her to a dedicated miscarriage clinic, and she has to be given some proper investigations, early pregnancy scan, and full support so that she can tide through that period. Now, very unfortunately, if she undergoes a second miscarriage also and she undergoes the third pregnancy, here is the time you step in with all the latest investigations, including karyotyping, including fish, including all the advanced tests, hormones, everything, so that you do not make a mistake. Now, further on from our speakers, because this whole session of 2 hours is going to be on RPL, you will hear lots and lots of RPL, and it is our earnest wish and hope that every audience of today's webinar can add these guidelines into his or her practice, which can benefit our patients in the long run and create a healthy world. So, Dr. Vishal, can I please thank the Foxy office bearers? A big thanks to Professor Dr. Rishikesh Pai, who is at present in FIGO, and it is because of his patronage that this webinar has seen the light of the day. Next. I also thank our dear Dr. Madhuri Patel, Madam, who is Secretary General Foxy, and she has met us recently. And she's such a gracious person and a very, very capable gynecologist. I'm sure because under her wings, Foxy is going to go to very, very great heights. Next, please. It is with great pleasure that I introduce Dr. Giten Sharma, sir, who is from Ahmedabad. Sir has joined, Purnima. Can you please call him, Purnima? And we'll give introduction when sir joins. Okay. And he is the sitting vice president under whom is the Foxy Endocrinology Committee working. And we really thank Dr. Kiten Sharma for giving us consent for this webinar. Next. And I'll speak a few words about the Chairperson Endocrinology Committee 2020 to 2023, Dr. Rakhi Singh Madam, a very dear senior and a very, very cooperative Foxian who has been the Vice Chairperson of UP State of Isar, peer reviewer of Jogi, and she is also the ICOG Governing Council member. She's recently got a seat in the recent election in the ICOG GCM. Madam is the director of Abalon Clinic in Noida, and she has been invited faculty in more than 350 national and international conferences, recipient of Foxy DC Datta Award, Foxy CS Dawn First Prize, author of Foxy Focus, which dealt with harmony of hormones in 2023, which most of us have read. She is also the developer of Foxy ICOG guidelines on PCOS and has written several chapters, received Wonder Foxian Award, Dhira Award, and ICOG Appreciation Award. We welcome Madam. I think she will join a little late. Next, I invite and welcome Dr. Anita Srivastav. She has joined us right from the beginning of the webinar. Thank you, Madam. She is the President of Obstetrics and Gynecology Society of Bhopal from 23 to 25. She is a postgraduate from NSCB Medical College, Jabalpur, resident from GMC Bhopal. At present, she is assistant professor at Chirayu Medical College Hospital, Bhopal. She has held several important executive posts in Bhopal Obs-Gynae Society and also been the past treasurer of Bhopal Menopause Society. Her special interest is in advanced gynec laparoscopic surgery, routine obstetrics, high-risk obstetrics, adolescent health, and cosmetic gynecology. We welcome you, Anita, madam. Would you like to?
Thanks a lot. Thanks a lot.
Yeah, we would like to have a few words from you.
Thank you, Monica. Nice introduction. But it is your efforts which made this webinar possible, this series possible. And with the guidance of all the elders and all the celebrities and all our stalwarts from all over the India, you have collected, you have chosen a few of them which are real pearls or who can guide us in all the field which you chose for this webinar. I hope this webinar will entitle us, many of us, keep what to do in recurrent pregnancy loss, which we come across day by day. I am in routine obstetric and I get many patients for them, and sometimes it is very difficult for us to guide them. Thank you. Thanks a lot. And I welcome all the dignitaries from all over India, Dr. Sneha, Dr. Rakhi, Dr. Pardesi, Dr. Chaitanya, Dr. Shushma, Dr. Korkute, Shashi Madam from our place, Dr. Purnima and Dr. Randhir Singh, Dr. Shabana Sultan from Bhopal. I welcome you all, and it was my pleasure to have you with us.
Thank you, Dr. Anita Srivastav. Next, I would like to welcome our, hello, Vishal. Please put the Now I'm going to invite our chief guest for this occasion. I will just continue with our local societies because sir is a little busy held up. So it is with extreme pleasure and lot of pride that I introduce Dr. Rajendra Singh Pardesi to this forum. He is a presenter of more than 28 papers in national and international conferences, 7 times Sir has been the best paper awardee in Foxy's AICOG conferences and invited faculty in AOCOG 2011 Taiwan, AOCOG 2013 Thailand. He was also faculty in FIGO 2006 in Malaysia, FIGO 2012 in Italy, has been the chairperson of Food and Drugs Committee of Foxy in 12 to 14 and awarded Dr. Mehru Hansotia Best Committee Award. He was VP Foxy from 2019 to 20 and VP AMOX from 18 to 22. At present, Dr. Rajen Singh Pardesi Sir is President AMOX from 2022 to 24. We welcome you, sir, and we would like to have few words of blessings from you.
Thank you, Dr. Monica, for kind introduction. Good afternoon, everybody. Respected Foxy office bearers, Dr. Kiran Kurtakoti, Dr. Sneha Boyar, Dr. Chaitanya Ganpule, Dr. Rakhi Singh, Dr. Pranjal Sharma, Dr. Supriya Arwari, Dr. Anita Srivastav, Dr. Sadhna Sultan, Dr. Shashi Srivastav, Dr. Shraddha Agarwal, Dr. Monica Singh, Dr. Randir Singh, Dr. Purnima, and friends. I am feeling really proud and honored to be a part of this webisode organized by Foxy Endocrinology Committee, Bhopal Vijay Society, and Bhopal Menopause Society. So I still remember the warm hospitality by Bhopal Obijay Society in 2017 when they invited us to take a CME on PCPNDT and MTP. It was that high time at that time, and it was attended by more than 100 delegates at that time. So I wish to congratulate Dr. Monica Singh, Dr. Randir Singh, and Dr. Purnima Tiwari for this event as convener. They had taken as pains and to arrange this webinar as President Bhopal Vijay Society told, and Dr. Monica Singh is very active in this. Topics chosen as endocrine spectrum of RPL, role of progesterone in RPL, unexplained and case-based discussions. I think that will cover almost all basics about RPL, which will be useful for our day-to-day practice. With the advancement of medical field, we can treat many causes of chromosomal abnormalities. Even now, science is ready for gene editing techniques also. And with surgery, we can treat anatomical defects with diagnosis. We can pick up many treatable infections. So endocrine imbalance can be easily managed in this era. With the galaxy of faculties, chairpersons and panelists, this will be a great event. I don't want to be in between you and the excellent scientific content, but still, I wish to every success to Dr. Sneha Boyar and Dr. Monica Singh for their future endeavor in Foxy.
Thank you,
I
sir.
wish every success to this webinar. Thank you. Thank you so much for inviting me. Thank you. Thank you so much.
Thank you. I cannot forget your words of encouragement, sir. It is like, talking to somebody elder from family, the way Dr. Pardeshi talks to you, it is so encouraging. It is so affectionate. I'm really fortunate to be in association, and it is all just because of Sneha, madam. Thank you, madam. Thank you. Next, we will, I think, have a guest of honor, Madam Sneha, ma'am. Should I continue with Bhopal Society introductions, or should I? Yes, ma'am. So I was on Dr. Shabana Sultan's introduction. Yeah. So next, I invite with great pleasure our Honorary Secretary of Bhopal Obstetrics and Gynae Society, Professor Shabana Sultan. She is a very keen academician and has published papers in national and international journals. Her main passion is working in groups to form treatment plans for India. So this was a PPH bundle. She's part of the team which developed this from Sevagram. She's held several good executive posts in the Bhopal Obs Gynae Society, is also an active executive member of MPSR, and has done several international projects along with Harvard University. She has got a keen interest in gynec oncology, high-risk pregnancy, and is the master trainer of cervical screening program. We would like to have a few words from you, Dr. Shabana, please.
Thank you for the nice words. And on behalf of Bhopal Obstetric Gynae Society, this is Symbiosis webinar series, and the credit goes to Monica Didi, and she's my Didi. I'm learning lots of many things from her. She is a very active member of Bhopal Obstetric Gynae Society. So I welcome Padesi sir, Sneha madam, and Kiran sir, Raki madam, for her contribution as in Foxy Endocrinal Committee and webinar of symbiosis along with BOGS and Bhopal Menopause. Everything Dr. Monica told us about RPL, and that we this webinar we will be enlightened about RPL. The one thing I want to mention that this RPL is associated with various psychological aspect and psychological distress also. So knowing about RPL, various causes, how to counsel the couple, because sometimes post-traumatic distress disorder may be noticed after this RPL. So a nice topic to learn. Thank you very much, Monica Didi, and thank you very much for all the stalwarts for joining. Thank you so much.
And thank you, Dr. Shabana. Today is World Mental Health Day also.
Yeah.
So every patient we are treating, this is the Breast Cancer Awareness Month. Sneha madam has brought in all the groups so beautifully. This is the World Mental Health Day because so many of our health issues now will be linked to the mental health. So
Yes.
we have to take it hand in, and every gynecologist has to be a good psychosocial counselor also.
Exactly.
Okay, next I would like to welcome Bhopal Menopause Society President, Dr. Shashi Srivastav Madam. She is our great mentor, great senior. Bhopal is so proud to have her. Under her wings, Bhopal Menopause Society is spreading like a lotus in the lakes of Bhopal. Madam is director of Saurabh Nursing Home, which is a very known hospital, renowned hospital of Bhopal. She is at present the president of Bhopal Menopause Society, life member of Indian Menopause Society. She is also a part of the PCOS Society and life member of Foxy. Her special area of interest is recurrent pregnancy loss, so she will be a big asset to this webinar. Madam, we request you to stay till the end. She has got keen interest in ultrasound. I started learning with her only and because of her only, and polycystic ovarian syndrome. Madam, please give us your blessings and few words.
Okay. Thank you, Monica. You have already chosen the best word for this webinar series, symbiosis, the beneficiary for the two and more bodies. Here we have so many bodies with us which are get benefited by each another. And this time, the endocrinology committee is with us. The endocrine is the basis of the all about the ops and gynae, what I said. And appreciate the vision of the Monica and Dr. Avdi to start this type of series, which is very, very beneficial to each and every person and every candidate who is listening to this type of series is really beneficial. And this time they chosen the topic RPL, which is very troubleshooting and always create a havoc for us when the patients come and we are not able to manage that. And this time I appreciate also that she's taken a great effort to collect the star of galaxies over there to give this opportunity to listen them and appreciate their vision. And I wish they go beyond the boundaries. So the future is yours. Bhopal must shine with your wisdom. Thank you, Monica.
Thank you. Thank you so much, Shashi ma'am. You're always so kind and so, generous with your praises.
Yeah.
Next, we would like to invite our guests of honor to this webinar. Dr. Shraddha Agarwal is there. Purnima, has madam joined?
No, she's not here.
Okay. Dr. Shraddha Agarwal, we also thank in her absence that she has kindly consented to associate Bhopal Menopause Society with the Symbiosis Series. I would like to now invite Dr. Sneha Buhar, madam, and it is a great honor for me to introduce ma'am because she is a shining star in Foxy, AMOX, and a great guide and mentor to so many of colleagues and juniors like me. She has been the Foxy Breast Committee Chairperson 2019 to 21. She is then the Governing Council member of ICOG 21 to 23, CEFOG Working Committee member, Foxy UNICEF National Expert, WHO FPAI certified national adolescent trainer. We can see the variety of feathers in Madam's cap, and she is also the AMOG's chair 22-24. And founder president of Vidarbha ISOPAP. Madam is the recipient of several awards like International MS Signature Award for Phenomenal Leadership in 2020, Asia's GCC Award 2021, Dr. S.N. Malhotra Individual National Award for Outstanding Work in Rural Obstetrics, Dr. Durusha Distinguished Community Service National Individual Award 2022, Anandibai Joshi State Award by Government of Maharashtra 2005, Lokmat Healthcare Excellence Award 2020, with more than 30 years of experience in OBGY, delivered more than 300 talks, written more than 30 chapters and articles in national publications. Madam, we welcome you. We welcome you. We are so humbled by your presence, and we would request a few words from you, ma'am.
Thank you so much, Dr. Monica. At the outset, I thank all the organizers first, and of course the Foxy office bearers. A very good evening to all of you, all the respected seniors and dear friends. My regards to Dr. Rishikesh Pai, the President Foxy, Dr. Madhuri Patel, Secretary General Foxy, Dr. Gitendra Sharma, who is the Vice President in charge of this Endocrinology Committee, and the Committee Chairperson, Dr. Rakhi Singh. My respect and regards to my AMOX President, my mentor in person, Dr. Rajendra Singh Pardesi, Guest of Honor and President-elect AMOX, Dr. Kiran Kurtakoti. Of course, the Bhopal team, Bhopal Obsgynae Society, the President, Dr. Anita Srivastav, Madam, of course, Shabana Sultan, dear friend, who is the Secretary of the Society, Dr. Shashi Srivastava, and of course, Dr. Shraddha Agrawal, and my dear friends and other key organizers for today's program, Dr. Monica Singh and Dr. Ranjit Singh. Dr. Purnima, who has so well coordinated this virtual event, I would say a very good evening to all of you once again. And of course, the topics chosen, they're very, very good, covering almost the entire spectrum. Dr. Rakhi speaking on the endocrine spectrum of RPL, Chaitanya speaking on role of progesterone, Supriya speaking on unexplained RPL, and of course the wonderful chairperson, Dr. Sushma Deshmukh from Nagpur, the president, Dr. Anjali Jamma from Solapur, Dr. Manisha Gate, the president, Chandrapur, Dr. Pranjal Sharma, president, Amravati, Dr. Vivek Virkar, Dr. President, Solapur, Dr. Vinod Shetty, and we have Dr. Ganesh, Dr. Meena, Dr. Manisha, Dr. Rujita, and Dr. Mayuri, and Dr. Shraddha as panelists. Of course, we have lots and lots of, we are going to gain lots of knowledge, and we're going to have practical tips from this panel discussion on evidence-based treatment algorithm by algorithm in RPL by our dear friend, Dr. Sandeep Nikhade and Dr. Pragati Khaladkar. Friends, we have been hearing lots about RPL, no matter whether it's right from the luteal phase support, and of course the variety of progesterone and the routes of administration, of course the role of IVIG and all, the role of psychological support, the tender loving care has its own place. It is proven time and again. I wish every success to this program and our dear friend Dr. Monica Singh, who is so hardworking and very vibrant. So definitely it's going to be a big success, and of course lots of gain in our knowledge. So Monica, thank you so much once again, and all the best to your future endeavor. Thank you so much. Over to you.
Thank you so much, madam. Thank you so much. It is really nice to hear your kind words, and you have, madam has taught me a very nice thing, which it never struck me, that she is, concerned about even the most senior person to the most junior person. She never ignores anybody, and for her, every person is important. Thank you, ma'am. Our next guest of honor is a very, very important gynecologist from Pune, Dr. Kiran Kurtakoti, who is at present Vice President AMOX and is the President-elect of AMOX. Sir has been the ex-chairperson MTP committee of FOXY 2009 to 11. In AMOX, he has held several important posts like ex-chairperson MTP committee AMOX, ex-chairperson medical education research training committee, and
Dr. Monica, that's okay. Dr. Monica, that's okay. Fine. Thank you so much. Thank you so much.
Sir,
yeah.
Yeah, sir. I want to really acknowledge your presence because sir is so kind. And when I called him up, he said, "Oh, Monica, how are you?" I was so happy that sir knows me. I thought I'll have to introduce myself, but sir is very, very humble person, and sir, we are really thrilled to have you here.
Thank
Can
you.
you bless us with few words?
Sure. It's a pleasure to be here on behalf of the AMOX platform. Greetings to all of you in Bhopal and all the viewers for watching this. And congratulations, Dr. Monica, Randir, and everyone in organizing this seminar because and you have tied up two societies, that is the Bhopal Society and as well as the Bhopal Menopause Society. So that's something different which I'm seeing. So thank you so much. And really a pleasure to see one of my close friends, Dr. Sneha, also as a co-guest of honor. So thank you so much for that also. I see a lot of faces. Sushma is there. Sushma is also a very dear friend from Nagpur, doing lots of work on hysteroscopy and of course RPL. So really a pleasure on behalf to be here as the guest of honor. Incidentally, the topic of RPL is such an old topic and it has been spoken for so many times, but ultimately we do not know what lies underneath. So as Neha rightly said, that ultimately is it only that what TLC matters, or there are any other factors which are related to RPL? So anyway, we'll be hearing on that through the galaxy of speakers. And I also congratulate Dr. Monica, Dr. Randir, and everyone in Bhopal Society for inviting me. Dr. Monica, you are doing a fabulous work. We hear a lot of things about you from the ISAR platform, but now you are going to do something different, and we wish you all the best on the Foxy platform also. So congratulations and thank you so much, Dr. Randir.
Thank you, sir.
You also from Pune.
Thank you, sir. Yes, sir. Thank you, sir.
Meeting you, both of you in Pune.
Thank you, sir. Yes.
At our AMOX conference also. So thank you so much, and my best wishes to both of you. Thank you.
Thank you, sir. Thank you, sir. So I think we will just deviate a little bit from the program. Before handing over to Purnima, I would like to invite the CV and introduction of Dr. Chaitanya Ganpule. Because Madam has not joined, I think Dr. Chaitanya is the chairperson-elect of Foxy Endocrinology Committee. We congratulate Dr. Chaitanya Ganpule for winning this coveted election. And can I have the CV of Dr. Chaitanya, Dr. Vishal Dave?
Chaitanya is one of the leading stars of Pune. For everyone who is watching, Chaitanya is the organizing secretary of the state conference, which will be holding in Pune shortly. And I'm sure most of you will love to come here to Pune to see him. He will be presenting his first Foxy workshop in Pune. That will be the first workshop of the endocrinology committee. He is doing a fabulous work in Pune for Pune Society, and now also now he'll be doing the same good work in Foxy also.
Yes,
thank you. Thank you so much for that kind words.
We are so honored to have you, Dr. Chaitanya. And your CV is so brief. I mean, if we compare it with your achievements and your accomplishments, it is you have put forward just I think 1/10 of your total achievements in this CV. But I welcome Dr. Chaitanya Ganpule. He's a very great senior, a very great friend. He has been the chairperson of Midlife Committee of AMOX, National Coordinator of Foxy Endocrinology Committee, and the chairperson-elect also. And sir, we all know he is the director of Pearl Women Hospital, Yash IVF in Pune, as well as in Satara.
Thank you so much for that kind introduction. That's
can we have a few words from you, Dr. Ganpule?
Monica, thank you for inviting me here. And I would like to thank you all because it's all because of your support and the trust that someone reaches the place. It's not because without your support and trust. So I would like to have my gratitude towards all of you. All my seniors, my teachers are here, and it's a very wonderful program which you have put together on RPL, wherein it's as Dr. Kiran said, it's a very old topic, but still we have more and more evidences coming out which are supporting this way or that way. Those which were supported in the past were out of use for some years in between. Then again they come back. So this keeps on going on, and that's how the science evolves. So very nice that you have come up with this this webinar and this concept of symbiosis. I like that, which you are doing along with different societies of Foxy. And Randhir has been my very close friend. You both of you obviously, but. On all the best for your future endeavor in Foxy. As Kiran said, that we have been knowing you on ISAR platform, but welcome to Foxy platform as well.
Thank you. Thank you so much.
Thank you, Chairman. Thank you.
So next I hand over the program to my coordinator, Dr. Purnima Tiwari. We all know her. She has been with me for now a long time, and she is totally doing all the coordination of the Perfection series of ISAR as well as the Symbiosis series along with Dr. Shabana Sultan. She is a consultant of IVF and reproductive medicine in Apollo Sage Hospital, Bhopal, alumnus of MAMC Delhi, been awarded the Foxy Traveling Fellowship, and recently I just wanted to tell you that she has received a very good award, the Manish Pankar Award in ISAR, and she will receive it in ISAR Bhubaneswar at the hands of Dr. Nandita Pashetkar. Welcome, Dr. Purnima, and please start the first session.
Thank you so much, ma'am, for such a kind introduction. And now I would like to invite our next chairperson, Dr. Sushma Deshmukh, ma'am. Ma'am is Director, Central India Test to Baby Center, Nagpur, and she is HOD of Ops and Gynae, Getwell Multi-Specialty Hospital and Research Center. She is Chapter Secretary Vidarbh IFS 21 to 24 and President Nagpur Ops and Gynae Society 23 to 24. Ma'am has organized 2 national and 1 international hysteroscopy carnival. She is a regular faculty for Global Hysteroscopy Congress in Barcelona since 2017. She has written more than 25 academic and non-academic books and is conducting public awareness programs for adolescent, reproductive, and menopausal age group. We welcome you, ma'am, on this platform. Dr. Sushma, ma'am. Ma'am is there?
Yes. Yeah, I saw Sushma ma'am. Yes, Sushma ma'am is there. Madam,
thank you very much.
Yes, ma'am. Would you like to speak, ma'am, about the... Achha, you are going to invite both chairpersons? Yeah.
Yes, ma'am.
Yes.
Thank you, ma'am. Our next chairperson is Dr. Anjali Sachin Jama, ma'am. Ma'am is consultant at Jama Hospital and Laparoscopy Surgery Center since 2000. She's a pioneer in cosmetic gynecology in Solapur and having area of interest in cosmetic gynecology. She's President Solapur Ops and Gynae Society 22 to 23. She has been Secretary Solapur Ops and Gynae Society 15 to 16 and has been Treasurer Solapur Ops and Gynae Society 13 to 14. She has been organizing secretary for 2 zonal conferences. Ma'am has been invited as faculty for state and national conferences as a cosmetic gynecologist, and she has delivered public speeches on teenage problems and gynecological problems at many schools and colleges. We welcome you, ma'am, on this platform. Dr. Anjali, ma'am, thank you so much for joining us. Ma'am has joined.
So I think Sushma ma'am can start the first.
Yes, can you hear me? Hello?
Yes, ma'am, we can hear.
That's actually my link, yeah.
Yeah.
I would like to hand over the session to our chairperson for introduction of our speaker.
Yeah. Respected chief guest, Dr. Rajendra Pardesi, guest of honor, Dr. Sneha Boyar and Dr. Kiran Kurtekoti, and all regards to Dr. Rishikesh Bhai, Madhuri Patel, a very good evening to all. At the outset, I would like to thank Foxy Endocrine Committee and Bhopal OBGYN and Menopause Society, especially my friend Dr. Monica, who has organized a wonderful this Symbiosis series. Today we are going to get blessed about all important tips and tricks about RPL. You know, to search out RPL etiology, it is not so easy. You have to find out twist in pregnancy, screen about the cause, that is anatomical, immunological, work with hormonal harmony. But its cause is nowhere. It could be somewhere. And to deal with unexplained infertility, it is really difficult for sure. So let's learn from Dr. Supriya Arwari about the unexplained RPL. As we know, she is an all-rounder faculty and the like Durga Durgotsav is near, and like a Durga Mata, she works with many hands with superb outcome. So, oh God. So yeah, she's a consultant obstetric gynecologist, infertility specialist. She's a trained at KM Hospital and Madia Hospital. She's practicing at Suparna Hospital.
Ma'am, I think it's okay. We can start with the scientific session.
Okay, yeah.
Thank you. You have already said the sweetest words ever by calling
Yeah,
me
okay,
one of
we can
like
start.
a Durga.
Yeah,
So
okay,
I think we can just go ahead.
Yeah, okay, yeah.
So can I just start sharing my slides?
Yes, yes.
Actually, I was just getting my link. It will disturb. Now I'm okay with my link.
Dr. Supriya, I just want to speak that you're such a sweet person. You're such a sweet person. You're such a senior person, but when somebody meets you, you are like a friend, you know. And you can make anybody laugh when you're on stage. You can make all the audience laugh.
Yeah, Dr. Monica, I also add one word, Dr. Monica. So I have always seen Supriya ma'am always a smiling face. A smiling.
Thank you so much, sir.
He
That's
makes
so kind
the
of
whole
you.
room lighter note, on a lighter note and a comfortable note.
Yeah. Good evening, Rakhi ma'am.
Welcome. Good evening, Rakhi ma'am.
Thank you all of
Good
you.
evening. Good evening.
Good evening, Rakhi.
Dr.
Congratulations.
Dr. Supriya, can we have 2 words from Dr. Rakhi? She has just joined before you.
Sure.
Yes, yes. Rakhi ma'am, we were waiting for you, and
No. Please continue the session as the time. Let Supriya give the talk. Please continue.
Good evening, madam. Good evening.
Okay, ma'am.
Okay, ma'am. I will start slide share.
Yeah.
Okay, so at the outset, I would like to thank the organizers for having me here to talk on the subject of unexplained RPL, especially Dr. Monica Singh, who's been working very hard. Thank you, Rakhi ma'am, not only for being one of the key persons in this webinar, but also allowing me to speak earlier because I have another commitment later on. So as usual, you know that I will always begin with a shairi. RPL, as we all know, dear friends, is something which really, hounds our patients, and it is, infertility altogether on a different level. But especially RPL, it is like haath ko aaya aur muh na laga. It's really sad for the patient, and therefore these 2 lines come to my mind कि कुछ अधूरा था जो पूरा हुआ ही नहीं, कुछ अधूरा था जो पूरा हुआ ही नहीं, कोई मेरा था फिर भी मेरा हुआ ही नहीं. So this is ये इस जज्बे के साथ पेशेंट हमारे पास आते हैं, often to get their problem solved, and therefore especially unexplained RPL is something that is not only hounding the patient but also hounding the practitioner. So what are the various causes which can cause this kind of problems? As we know, around 5% genetic factors, 10 to 15% anatomic factors, 20% autoimmune factors, 0.5 to 5% infections, around 20% endocrine factors, about which Rakhi ma'am is soon to speak about. And there is this big chunk of 40 to 50% of cases where the cause of the recurrent pregnancy loss is just not diagnosed. This is what we deal with when we call the unexplained group. And this also includes the non-APLA group. APLA group, at least we can investigate and find out that they have some autoimmune disorders or thrombophilias. But this is the group which includes the non-APS thrombophilia. So APS thrombophilia is probably quite easy to diagnose, but not the rest. What are the various causes of reproductive failure? Infections, we all know. In fact, the patients are also so concerned. Something like a torch test, if we don't perform on them, they are very concerned कि आपने क्यों नहीं torch test किया? फलाने डॉक्टर ने तो बोला torch test कराना चाहिए था. Hormonal and metabolic disorders, nutritional factors, genetic factors, maternal age, advanced age, I'll be speaking about it a few things. Paternal factors, very, very important, and lifestyle and environmental changes. Let us now go to this a little, cute little chart which will tell you In like a nutshell, what are the various causes that we need to look for when we are dealing with recurrent pregnancy loss? Now, one is something to do with the egg, then is something to do with the sperm, then is something to do with the embryo, then something to do with the endometrium, obviously where it is going to be nidating, and then the systemic factors which can generally affect the woman's health and consequently her pregnancy outcome. Now, what are the factors about the egg or the ova that we are concerned about? Number one is aging. Secondly, poor ovarian reserve. Cases of polycystic ovarian syndrome, we all know that PCOS are more prone to having recurrent pregnancy losses. And poor oocyte quality, which consequently leads to embryo quality being poor. Now, this AMH here and the antral follicular count can be a very good marker of whether we have an egg-related factor which is causing this unexplained infertility. We know that an increased AMH in PCOD or a very decreased AMH in something like a premature ovarian failure and an antral follicular count which is less can be as act as a marker of the ovarian function or the egg function. Also, aneuploidy is one of the main causes in women with increased age. I said I will speak about maternal age. Premature ovarian aging can also cause a decrease in the oocyte quality and quantity. And oocyte donation in such cases is shown to improve the results of RPL and therefore indirectly proves that maternal aging has a very big role to play as far as bad eggs are concerned, leading to RPL. Now, there is a decrease in the women with idiopathic recurrent miscarriage. We find that if the AMH and the estradiol are significantly deranged, these women are more commonly prone to miscarriage. So, like I said, AMH can act as a marker probably of women who can expect to have a little bit of increased chances of recurrent pregnancy loss in them. Now, what is the effect of dehydroepiandrosterone on oocyte and embryo yields, embryo grades, and number of IVF? Women who received DHEAS, it was in the study showed that there was definitely a significant increase in fertilized oocytes and the day 3 embryos. And the embryos transferred were also better in quality, and the average embryo scores per oocyte was also significantly better. So the benefits of DHEA supplementation, which in turn improves ovarian function, has been proved with beyond a doubt, and therefore all the more to reiterate that women with ovarian reserves diminished with increased maternal age and who are producing bad oocytes can definitely cause RPL, and these are the women in which this particular factor needs to be addressed. Now, there was a Cochrane database systematic review on antioxidants for female subfertility. Now, there is a lot of work being done and lot of being said also about antioxidant therapy. For now, it has been proved beyond doubt that oxidative stress can lead to very low quality evidence. We can lead to very low quality ovum. The systematic trials may not have sufficient, but there is definitely some amount of evidence that antioxidant therapy will definitely benefit, and therefore it is always better to give them the benefit of doubt and start some antioxidant therapy. After talking about the egg, now let us talk about the sperm, which is again a 50% partner in how the pregnancy outcome will come. Now, there are certain factors like Y microsome microdeletion, sperm oxidative stress. There can be sperm DNA fragmentation, sperm concentration or motility problems, and sperm morphology abnormalities. We do a semen analysis to diagnose most of these things, but something like a sperm DNA fragmentation is something which not all of us do regularly, but it can give a lot of information, especially in cases of RPLs or in fact also in cases of unexplained infertility, wherein we cannot really pinpoint what is the factor that is not allowing the lady to get pregnant. What investigation we would do in a male? A detailed sperm analysis from a good standard lab, sperm function test, the sperm DNA fragmentation, which I already spoke about, sperm fish for, especially to make sure we are not dealing with sperm aneuploidy, blood sugars, We can also do the parents karyotyping so that we can, diagnose whether there are any underlying chromosomal problems. Now, this is a kind of a flow chart which shows the percentage of damaged sperms which are counted and the DNA fragmentation index of the same, and what is the relation between DNA fragmentation and the fertility outcome. This is a really beautiful flow chart, and it has shown that when the DNA fragmentation index is less than 15, it is with a normal sample with a normal fertility potential. So minimum less than 15, I think, should be a cutoff, less than which it is very unlikely that this patient will conceive normally or have a normal outcome as far as take-home pregnancy is concerned. A DFI between 16 to 25 is a fair potential, but a more DFI more than 30, that definitely there is a damaged sperms with low fertility potential. So always DNA fragmentation is something that we should learn to do in clinical practice, especially when dealing with unexplained RPL, unexplained infertility. So if the fragmentation is taking place more than 30%, there is some serious problem and that needs to be handled. We'll now look about the relationship between sperm DNA fragmentation, the free radicals, and again antioxidant therapy with idiopathic repeated pregnancy loss. Now, this is a trial which was done among 42 men, and their partners had history of spontaneous miscarriages. The sperm motility in the group was lower than normal, what we would have expected, and the DNA fragmentation and the amount of free radicals were significantly higher. Okay, total amount of antioxidant was lower in the experimental group, and therefore the spouses of these men tended to have more and more chances of repeated miscarriage. So again, here this study itself proves that high DNA fragmentation can be a major contributor to RPL. Also, oxidative stress can lead to more and more chances of RPL, even in the men. So antioxidant therapy, I believe, for men as well as women, we should be considering. Now, let us look at the sperm aneuploidy and DNA fragmentation in unexplained recurrent pregnancy loss. Again, this was a multicentric trial, and this showed that increased sperm aneuploidy definitely was observed in unexplained RPL. I think this is quite obvious. If there is some underlying chromosomal or genetic problem with the sperms, it is more likely to land up with a pregnancy loss. And this is something, again, which cannot be easily diagnosed. Hence, I'm talking about it when I'm talking about unexplained pregnancy loss. Now, this is again a very busy slide, but a very beautiful chart which shows what oxidative stress can do to the sperm count, to the sperm motility, and basically there will be protein damage, there will be lipid damage, the membrane, biomembrane of the sperm is damaged, the DNAs are damaged. All these can lead to infertility. Not only infertility, it can also lead to recurrent pregnancy losses. Role of oxidants in male therapy, I've already talked about it, that we should definitely think about giving antioxidants not only to female partner but also to the male partner, because antioxidants, the oxidative stress can lead to around 25 to 40% of infertility. It can damage the plasma membrane. It can increase the DNA fragmentation, reduce fertilization rate, increase rates of embryo deaths, and decrease motility of the sperms. Next, we will go to the evidence-based suggestion about which, now I've spoken about antioxidant, but which antioxidants to give. If you go through the pharma market, you will see there is a host of like hundreds of antioxidants having thousands of different combinations. So we should be looking at which are the antioxidant that we should include in our therapy. And as per the trials, the strongly recommended ones are L-carnitine, coenzyme Q10, and lycopene. So any combination which contain these three should be preferred. There are some weak, suggestions, trials of weak recommendations of zinc, B12, vitamin C, and folic acid. Combinations are recommended, but now with increasing, NMC criteria and rules, I really don't know what kind of a prescription we will write. There are some 10, 15 products that are there in one product. I'm wondering how we will be able to write the generic names of all these. All the same, definitely we can, recommend this. Now, this is again a systematic review of a Cochrane database about antioxidant in male subfertility. Again, very encouraging results as far as antioxidant therapy is concerned. Let us now go to the embryo factors. We have spoken about the ovum factors, the sperm factors. What are the embryo factors that can lead to RPLs? Pre-gestational or the diagnosis, if you allow this embryo to be studied in a laboratory, more and more of these embryos are found to be aneuploidic. Okay, there are of course lack of various trials, and the cost versus benefit of doing PGS for each and every embryo, even in an IVF setting, needs to be really considered, because especially of the cost that is incurred in doing all this. Now, pre-implantation genetic diagnosis, it definitely improve the reproductive outcome in couples with RPL, owing to being able to diagnose the structural chromosomal problems. And this is again a systematic review about the same, that the live birth rate, it's a huge study. See, you can see pooled study of nearly 900 couples. Some of them had conceived naturally. So, and among these, some of them had undergone IVF and PGD. And the patients with RPL and structural chromosomal rearrangement, they were counseled that good reproductive outcome can be achieved through natural conception also. And this trial therefore reiterates the fact that just because the patient has RPL, directly IVF with PGD should not be offered as the first line of therapy, because it has unproven benefits, and the additional costs and probably the potential complications of IVF are very high. So we should be very, very, careful, or we should be very responsible when we recommend IVF for patient just because she is a case of recurrent pregnancy loss. Now let's go to the endometrial factor. Endometrial thickness, vascularity, receptivity. These all are very important as far as RPL is concerned. And often now, of course, with good ultrasound technologies and sonologists becoming more and more aware, and gynecologists doing their own sonographies, this is something that can be diagnosed more and more nowadays. But still, it is not an easy job to diagnose endometrial factor. Women with RPL definitely have increased levels of pro-implantation cytokines in the endometrium, and therefore either they will be subfertile or they will end up with recurrent pregnancy loss. Decreased endometrial vascularity and receptivity in unexplained recurrent miscarriages, and during the mid-luteal and early phases. This beautiful trial was conducted in Taiwan. And they have shown that the endometrial thickness, volume, and the vascularity, especially of the mid-luteal phase endometrium, is significantly lower in the RPL group, therefore showing a direct connection of all these factors in causing recurrent pregnancy loss. Similarly, a comparison of the endometrial and subendometrial vascularity was assessed in healthy females and in women with recurrent pregnancy loss, and they found that the endometrial vascularization index, that is the vascularization flow index, as well were reduced, and therefore the subendometrial, not only endometrial but the subendometrial factors can also cause these kind of reproductive losses. When we talk about vascularity, we are talking about something that comes from the myometrium and enters in the subendometrial layer. So there the problem can lie at that level also. Next, we talk about the impaired endometrial and subendometrial perfusion. Already about the vascularity we've spoken about. Now, power Doppler can be a very good and sensitive tool in comparison with a color Doppler at detecting low velocity flow, and hence improves visualization of small vessels, especially at the endometrial level. Angiogenesis, as we know, plays a very critical role in various female reproductive functions. Apart from reproductive functions, also in nidation, it is one of the most important factors. Now, some drugs like aspirin, glyceryl nitrate, angiogenic growth factors, sildenafil, these are shown to have a good effect not only on endometrial perfusion but also on endometrial thickness. And therefore, if we suspect the endometrial cause, we can think of supplementing these drugs in the preconceptional stage itself. Now, this again is a a fertility sterility publication that I have cited, wherein chronic endometritis in women with recurrent pregnancy loss or fetal demises were studied. Now, these were women with a history of 2 or more pregnancy losses, usually less than 10 week size, or a single demise more than 10 week size. And all these women were given an endometrial biopsy. Chronic endometritis was diagnosed, and then it was treated with antibiotics, and the overall prevalence of chronic endometritis in this case was as high as 9%. Now, the pre-pregnancy, they were treated for the chronic endometritis, and this group later on post-treatment got a very good result for birth rate, live birth rates compared to the pre-treatment. You can see here the pre-pregnancy low birth rate was as low, live birth rate was as low as 7%, and after treatment it rose to 56%. So this is something which is easily treatable and therefore merits our attention. Also, decrease endometrial vascularity in patients in antiphospholipid antibody associated recurrent miscarriages. They were again studied during the mid-luteal phase. Both the groups had similar endometrial thickness and volume. Now, remember, the externally what is visible is similar. Endometrial VI, FI, and VFI, and the subendometrial FI were significantly reduced in the RPL group. So therefore, just studying the endometrial thickness will not be sufficient. The endometrial vascularity also needs to be studied, especially when we are dealing with RPL. And endometrial and submetrial vascularity definitely has a significant role to play in recurrent pregnancy loss, not only recurrent loss, but also in unexplained infertility. Often we find that everything else being good, still women don't conceive. And these are then the subtle factors that we should be looking for. Now, this is a study of women with T-shaped uteri. They were surgically corrected. Now, 56 patients, they underwent a metroplasty by office hysteroscopy. The anatomical outcomes were assessed with pre and post-op measurement of the transosteal, ischemic, and myometrial diameters and the uterine volume, and the reproductive outcome was assessed. And the hysteroscopic treatment significantly increased the volume of the uterus. 80% of these patients who had RPL in the past conceived either spontaneously or with assisted reproduction. So again, this goes to show that the endometrial cavity, the shape, the volume have a very, very important role to play in women with RPL. And the office hysteroscopic metroplasty results in significant long-term expansion of the uterine cavity and improvement of the reproductive outcome in T-shaped uterus. It goes to say that definitely there is a role if there is an ultrasound or a sonosalpingography or a even nowadays with a 4D ultrasound, you can diagnose a T-shaped uterus. Definitely it would be worth counseling them to undergo a metroplasty by hysteroscopic means. This was again a study for the resistance of the uterine radial artery. Now, this is something that not very commonly we get to study, but this is again a beautiful study that it's not very easy to get these investigations done, but it is such a nice study, therefore I've included it here. This was correlated with the peripheral blood NK cell fraction and improvement after low molecular weight heparin in women with unexplained recurrent pregnancy loss. Why I have included this here is because low molecular weight heparin is something we can easily give. The diagnosis may not be easy, but the treatment is quite easy. So pregnant women with RPL with pro-BNK cell fraction displayed a positive correlation with URI, increased RI. The URI was significantly reduced after 1 week of low molecular weight heparin treatment, and the pregnancy outcome in these women, those who are not treated, were definitely poorer compared to the treated group. So definitely low molecular weight as a treatment can effectively improve pregnancy outcome, especially in cases of RPL, and of course in cases of those which have diagnosed APLA syndrome. I told you in the beginning that this unexplained group consists of non-APLA thrombophilias, and often non-APLA thrombophilias are not easy to diagnose. But this study has shown beyond a doubt that low molecular weight heparin therapy will definitely benefit these women. Please let me know when my time is up so that you can, I can wind up my, because RPL and unexplained RPL, we can go for, for months together. But all the same, I'll try to stick to be on time. Now, this is again one more important study about the role of low dose aspirin on mid luteal phase uterine artery blood flow index, and in patients with recurrent pregnancy loss. The mean PI and the SD of the uterine arteries in recurrent pregnancy loss were found to be significantly higher, and definitely higher in the RI was much higher in the RPL cases. They in fact turned out to be quite a good indicator of increased pregnancy losses, and uterine blood flow decreases during the luteal phase in patients with RPL, and low dose aspirin reduced this particular problem and induced a reversal in the uterine blood flow. And this is where again, although the diagnosis is not easy, definitely the treatment is easy, and therefore I'm stressing on these particular studies that role of low dose aspirin in unexplained RPL is definitely there, and it is there to stay. This is the evidence base which about immunotherapy. Now, immunotherapy, much has been said, much has been talked about, and I know there are advocates of immunotherapy who are giving immunotherapy regularly with good results. Although the current evidence base does not support the clinical use of immunomodulation therapy, especially in patients undergoing IVF, evidence is insufficient to support the beneficial effect of IVIG as further explained in this particular trial. And high quality studies are needed, and we have people who are doing these kind of studies, who are giving patients regularly immunomodulation therapy, and I think we should be looking forward to more such studies coming. Because even personally, I must confess that even I have tried immunoglobulin, not IV but intramuscularly, every 3 weeks, and certain women who we really can't understand what is the cause, 7-8 repeated abortions, have done well with immunoglobulin therapy. So really I'm looking forward to more studies about the same. Other factors to quickly go through: environmental factors, obesity, vitamin D I'll speak about in a minute. Role of folic acid, it is beyond any doubt, because we know folic acid can cause increase in neural tube defects and probably cause some aneuploidies, not only in females but also in the men, and therefore folic acid should be supplemented, especially for the women. But about stress, about micronutrients, come on, let's see one by one. Now, these are 6 studies which have correlated obesity with recurrent pregnancy loss. Now, this is so very important because it is so easily modulated. Lifestyle changes, weight loss is something we can easily do. A woman who has a chromosomal underlying problem, it's not easy to treat. It is such a tough job to explain to her that she has to go for a donor oocyte. But a woman who is obese, it is so easy for her to change her lifestyle and have weight loss, and therefore consequently, improve her outcome as far as pregnancy is concerned. Obese women with a history of RPL have a high risk of future pregnancy losses, and this is something we should stress to them. And this risk is not as much in the overweight group as compared to the obese group. So, the BMI, I think it would be worth calculating and explaining to the woman she should take 6 months off, lose weight, modify her lifestyle, and come back for whatever treatment. Now, this is again one more good study about vitamin D, which is easily available, cheaply available, can be given to all women. And studies have reported a high prevalence of vitamin D insufficiency in women with RPL, and could be associated with the immunological dysregulation, in which vitamin D can play an important role. And therefore, having recognized the benefit, there is no doubt about the beneficial role of vitamin D in women with RPL. Homocysteine, again, lots being said, homocysteine, folic acid, and B12. Together with increasing the number of abortions, the average homocysteine concentrations grew. The average folic acid the B12 concentration lowered. So homocysteine has an indirect effect, or you can say inverse proportion to folic acid and B12. The more the homocysteine rises, the lower will be the folic acid, the lower will be the B12. And therefore, if we are giving antioxidant, they can also help in lowering the homocysteine levels. As also, we should be thinking of supplementing folic acid and supplementing B12 so that the lady can have a better outcome in the subsequent pregnancy. Now, this is a trial about increased risk of women with unexplained RPL with adverse outcomes at term. Now, this woman has come to you for RPL. You treated her RPL. Now she's going ahead with this pregnancy. Luckily, she's crossed the first trimester mark. How is going to be their long-term behavior over the next few months, and how is it going to be, how the pregnancy outcome is going to be? This is again a really wonderful study, and always it reiterates the fact that sometimes, we do a lot of work, and it is the right of every patient who has RPL, who has infertility, to take treatment and have a live baby. But sometimes we tend to forget that nature is trying to protect her from something adverse. And often this is something we don't realize. And many of you will agree with me that such kind of women with RPL who eventually go luckily go ahead with the pregnancy, or women who have conceived with IVF, invariably they land up with some problem or the other as far as obstetric complications are concerned. Now, there is a slight increase in the preterm delivery rate. There is an increase in hepatic cholestasis. More frequently, they will land up with a cesarean section. They can land up with a risk of diabetes, gestational diabetes. And therefore, these women, we cannot tell them, please don't get pregnant because you will have some future problem. But as obstetrician, we should be very careful to monitor them very closely, get all the investigations done, repeated ANC checkups, and make sure we are not missing any of the complications. Often it happens once they get pregnant, they also feel relieved that they have crossed the second trimester, and then they just go to their native place, gaon chale gaye, ghar chale gaye, and they neglect the pregnancy. That should not be the case. Now, this is actually speaking my last slide, where maternal recurrent pregnancy loss, whether it is associated with increased long-term neurological morbidity in the offspring. This again is one of the good studies that I have brought up. The multivariable model exhibited an independent association between maternal RPL and childhood epilepsy. And a history of maternal RPL appears to be independently associated with long-term neurological morbidity of the offspring. So when I say once again that nature is trying to be protective, nature always wants the best for the next generation. And often that is why these women usually land up with an RPL. Somehow we are able to help them tide over that first trimester, and then maybe their children may suffer from neurological morbidity. So we should be informing these women to keep their children under surveillance even after birth. Maybe have a good neonatologist in tow. A history of RPL can also increase the risk of childhood gastrointestinal morbidity, especially inflammatory bowel disease. So I think this is something where we can do more work, maybe have a retrospective study. This is something which can be easily studied by the pediatrician and the neonatologist, and try to correlate with the woman's past obstetric history, whether her mother had repeated RPLs. So at the end of the day, I think as obstetricians and gynecologists, this is ultimately our aim, that we can create a happy family and a happy couple where there were none. Often we know RPL can be a cause of marital discord, lot of stress for the woman involved. Unfortunately, social taboos will always tend to blame the woman. In a nutshell, we should not forget to investigate the males also in detail. Just don't take the semen analysis at face value. Think about doing DNA fragmentation. Think about doing their sugars, their hormonal profile. Take an andrologist on board and get them investigated. Always this should be a kind of a team effort where maybe even a genetic counselor will give us some advice, how to approach this patient. So I think in the end, with these kind of investigations, these kind of and simple interventions, like giving vitamin B12, like giving folic acid, like giving vitamin D, like giving antioxidants, which are not only going to help the woman with her obstetric side, but also generally are good for her health. So this is something that can be easily changed. Of course, at the end of the day, good counseling, giving a patient ear to the couple, hearing what they have to say, letting them vent their frustration also will help relieve their stress and go a long way in, treating recurrent pregnancy losses. So at this point, I'll stop sharing my slides, and I'll once again like to thank the entire committee of today's organizers, and thank you, Monica. Thank you, Chairperson Sushma ma'am, once again for those very kind words, and all
Really
the
excellent.
that had come ahead of me. Thank you so much.
This was such an excellent talk.
Really
This was such a
excellent.
comprehensive talk which set the platform for the whole webinar.
Thank you, ma'am. And I would like to thank Dr. Kedar Ganla. He helped me with the slides and all these various studies. Really, I love these. They're such good studies, very important and clinically relevant, not something that you
really,
just
Supriya,
take a paper on.
It was very nice, and you covered almost everything, because unexplained RPL is really very vast topic, and you covered it very nicely, including with the couple evaluation, proper evaluation. And one thing I like that you mentioned about the chronic endometritis. Really, it is very important, because in my also talk always I address how like hysteroscopy is like a wonderful modalities with us, that we can diagnose it very well. Even I am having my own studies that diagnose chronic endometritis, and even the treatment is very simple. You have to do only doxycycline, and the results are really
Yes, madam.
improving.
Yes, madam.
And really, I take this opportunity to invite you all for the Nagpur Hysteroscopy Carnival on 15th, 16th, 17th of December. 4 international faculties are there, so you're most welcome.
Definitely, ma'am. Okay, let's move to the second session.
Thank you once again. And also,
thank
I
you.
will take this opportunity to invite all of you to Thane on 28th and 29th of October. We have the National Oncology Conference, and we promise that conference will be something that is there for the grassroots gynecologists to take home as well. Not only a specialty conference, but something where all gynecologists can take home good messages. So I invite you all. I will send the brochure in the group also. Please, those who can come to Thane, we will be really happy to host you. Thank you so much. Thank you once again, Rakhi ma'am. And we can, I think, go ahead with the rest of the webinar. Thank you.
Purnima, let us move to session 2.
Yes, ma'am. So, so for our second session, I would like to invite our chairperson, Dr. Manisha Ghate, ma'am. Ma'am is president of Chandrapur OBGY Society 23 to 24 and West Zone Coordinator, Food, Drug, Medical, Surgical Equipment Committee, FOXY. Ma'am is Secretary General, ISOPAR Vidhab Chapter. She is Chairperson, Women's Doctor Wing, IMA Chandrapur 21 to 22. She has been Secretary of Chandrapur Obs-Gynae Society 16 to 18. She has been Vice President of IMA Chandrapur 2019 and also Director of Chandrapur Test to Baby Center. Ma'am is recipient of National IMA Dr. Kanak Goyal Award for MFE Motherhood. Ma'am is Director of Santaji Mahila Nagar Sahakari Bank, Chandrapur, and she is first to bring and start colposcopy in Chandrapur. Ma'am has been invited as faculty speaker in state, national, and international conferences. Having area of interest as laparoscopy, infertility, and colposcopy, and work as consultant in Ghate Surgical and Maternity Hospital, Chandrapur. We welcome you, ma'am, on this platform. Dr. Manisha, ma'am, thank you for joining us. Our next chairperson is Dr. Pranjal Saraswat Sharma, ma'am. Ma'am is Director, Sharma Hospital, Amravati. She is Director, RIMS, Amravati, and also Zonal Coordinator, AMOX 18 to 22. Ma'am is Chairperson, Website and Publication Committee, AMOX 22 to 24. Ma'am is Organizing Chairperson, AMOX Zonal Conference, AdolisCon 2020. Has been Organizing Secretary, Zonal Conference, AMOX 16, also in 2020. She is past Chairperson, Beti Bachao, Beti Padhao. Ma'am is State IMA past Vice Chairperson, PCPNDT State IMA. She is recipient of late Shelza Chaudhary Award for work in OBGY, and she has presented papers in various conferences. She is recipient of the Champion of FOXY Award. She is recipient of V for Istri Puraskar 22. She has received Best Paper Award at FOXY 22 and NARCHI, and she has received Best Paper Prize at AMOX State Level Conference 22 and has been faculty at various conferences. We welcome you, ma'am, on this platform, Dr. Pranjal, ma'am. Ma'am is there? Dr. Pranjal, ma'am. Dr. Manisha Kati, ma'am.
Yeah, Dr. Manisha
Yes.
can introduce Dr. Chaitanya.
Yes. So, ma'am, yes, I would like to hand over the session to you for introduction of Dr. Chaitanya.
Yes. Dr. Chaitanya Ganapule, he actually does not needs any introduction. He is the director of Pearl Women Hospital and Yash IVF Pune, and director of Noble Yash IVF and Satara Yash IVF, recipient of Times Health Icon 2020, and is an invited faculty and publication in national and international journals. Has written chapters in Jeffcott's textbook of gynecology, Foxy Focus, and others. And he's also the chairperson elect for Midlife Committee AMOX and National Coordinator and Chairperson elect for Endocrinology Committee Foxy. With this, I hand over to Dr. Chaitanya Ganapule, sir. Sir, the stage is yours.
Thank you, Chairpersons Dr. Manisha and Dr. Pranjal for holding the session. At the outset, I'm sorry, I've been down with fever for last 4-5 days, not yet recovered. So excuse me with my voice. And if you can just allow me to share my screen. Yeah, so I would like to thank Dr. Monica and Dr. Randir for giving me this opportunity to be here. I would also like to thank Foxy President Dr. Rishikesh Pai sir, Secretary General Madhuri Patel Madam, Gitendra Sharma sir, and of course Dr. Rakhi Singh, who has been my mentor and who has guided me throughout since I have become a member of this committee for last 6 years. And once again, thank you all for showing your trust in me and electing me as the chairperson for the Endocrinology Committee Foxy. Dr. Supriya has nicely taken us through the unexplained recurrent pregnancy losses and what are the different reasons for unexplained RPL and what could be done about it. So I am going to restrict myself to only one aspect of it, and that is the role of progesterone in the management of recurrent pregnancy loss. What is the current scenario? What does it has to see? So as you all know that miscarriage causes untold pain to the affected families, and 1 in 4 pregnancies end in miscarriages. So let's discuss how and why miscarriages occur and and the ways to manage them. So what is the current scenario, or what is the current trend in India as far as the miscarriage and pregnancy loss is concerned? So the pregnancies may be lost at any time after fertilization. So the overall, the occurrence of RPL, pregnancy losses could be up to 30%. Out of which 30% are lost prior to implantation. Therefore, we don't come to know because the woman presents to us with a little delayed periods, and we don't get into testing her or investigating her whether she was pregnant or not. So we don't come to know whether she was pregnant at that time or not. Or many times they don't even come to us. They just believe that it was just a bit of a delayed period and they carry on with their life. 30% of them occur following the implantation, but before the missed period. So again, these are the ones which we miss out, and only ones which we can catch are the ones which actually come to us after they have missed the periods, and we diagnose them that they had pregnancy, and then they land up in a miscarriage. So only 10% of these total pregnancy losses are the ones which we actually catch hold of. Rest of them, probably even though they are having pregnancy losses, we don't label them as pregnancy losses, or we don't catch them at that particular moment. So what is the incidence of pregnancy loss? The global and the Indian context, miscarriage is a frequent natural event occurring in approximately 20 to 30% of the pregnancies, as I said, but only 10% of them we could diagnose. About 22% of these pregnancies are lost before the pregnancy is clinically recognized. Nearly 80% of all the pregnancy losses occur within the first trimester. So only few of them will occur in the second trimester, and the reasons are different when it occurs in the second trimester and when it occurs in the first trimester. I'm going to stick myself to the first trimester. I'm not going to go into the details about the reasons for second trimester recurrent miscarriages. Spontaneous miscarriage rate is higher in Indian women as compared to Western women. Age, maternal obesity, excessive caffeine, and alcohol intake are the known risk factors for the miscarriages. So how do we classify the miscarriages? We can classify them into threatened miscarriage, septic miscarriage, inevitable miscarriage, recurrent miscarriage, and missed miscarriage. So previously we used to use this word abortion. Now it has been replaced completely by miscarriage, and therefore we are not using the word abortion per se anytime nowadays. So again, this symbiotic webinar is regarding the recurrent miscarriage. Therefore, let's stick to the recurrent miscarriage, which is defined as 3 or more consecutive pregnancy losses. What could be the possible causes of these miscarriages? Can be divided into 2 factors: maternal factors and the fetal factors. The maternal factors could be because of the maternal age, which leads to aging of the oocytes, leading to an aneuploid embryo, leading to an recurrent pregnancy loss. There could be some hormonal and metabolic disorders like hypothyroidism, diabetes, which can again lead, or polycystic ovarian syndrome, which can again lead to the hormonal and metabolic imbalances, leading to recurrent miscarriages. Infection is another reason why you can have recurrent miscarriages, and obviously lifestyle and environmental factors like obesity, alcohol intake, smoking, everything, tobacco intake in any form can lead to miscarriages. There could be fetal factors as well, chromosomal anomalies, as I said, and the embryonic defects which can occur at the mutational level, and that leads to the recurrent pregnancy losses. So what are the current trends in the management of recurrent pregnancy loss? As I said, the recurrent miscarriage is defined as 3 consecutive pregnancy losses prior to 20 weeks from the last menstrual period. If you see the incidence rate, the recurrent pregnancy loss affects about 1 to 5% of the couples. Why do you want to define it very precisely? Because defining it will tell us whether it is likely to affect our future pregnancies or the subsequent pregnancies, and if I can diagnose the correct cause for this recurrent pregnancy loss, and then if that is treatable, obviously I'm going to reduce the chance of her recurrent pregnancy loss, and I'm going to I'm in a position to give a healthy baby. That is the reason why we need to define what it is, how it is defined, and what are the incidence rates. So what are the different etiologies for these recurrent pregnancy losses? Where there are different etiologies which are put down. It could be because of parental chromosomal abnormalities. It could be because of untreated hypothyroidism, untreated diabetes mellitus. Some uterine anatomic abnormalities like uterine septum could lead to unicornate uterus, bicornate uterus. All these can lead to recurrent pregnancy losses, and obviously immunological causes like antiphospholipid antibodies syndrome. However, all these are defined or measurable etiological factors for recurrent pregnancy losses. But there is one more which can lead to recurrent pregnancy loss, and nowadays its association is more profoundly found in many evidences, and that is progesterone deficiency and its association with the recurrent miscarriages. Luteal phase defect is a condition in which inadequate production of progesterone by the corpus luteum takes place, and consequently the results in inadequate development of the endometrium. So initially we were in a double minds whether really luteal phase defect lead to recurrent pregnancy losses or not. However, several studies have reported that lower than normal serum progesterone concentrations in recurrent miscarriage patients with delayed endometrium compared with those with normal endometrium. So nowadays, there are quite a few studies which have proven that yes, low levels of progesterone can lead to pregnancy loss, and not only pregnancy loss, but also to recurrent pregnancy loss. Findings from a study supported the existence of the condition of luteal phase defect as an entity that has clinical significance in recurrent first trimester spontaneous miscarriage. So now we have come to a conclusion that luteal phase defect is an etiological factor for recurrent pregnancy losses, and treating this luteal phase defect with the help of progesterone could lead to reduction in the incidence or evidence of recurrent first trimester losses. How are we going to diagnose these recurrent pregnancy loss women? Obviously, it will depend upon the etiology at which we are looking at, depending upon the history which we are taking in, which we have taken in detail to begin with. If it's a genetic cause we are looking at, we would be going ahead with the parental karyotyping. If it's an anatomic cause, we will do an HSG, or rightly said by Dr. Deshmukh madam, we will do an office hysteroscopy or a 2D or 3D ultrasound, saline infusion, sonohysterography, so that we can know the anatomic cause of it. If it's an endocrine cause, TSH possible testing for insulin resistance, serum prolactin levels, ovarian reserve testing, and antithyroid antibodies can be done. If it's infectious, no evaluation is recommended unless patient has evidence of chronic endometritis, cervicitis on examination or on hysteroscopy. And then we have taken an endometrial biopsy, we have sent it, and then we have come back with a report which says that yes, there is evidence supportive of endometritis, chronic endometritis, and then we can give her antibiotics for the same. Autoimmune cardiolipin, anticardiolipin antibody levels, IgG, both IgM should be done. Lupus anticoagulant. Homocysteine, factor V laden, prothrombin promoter mutations, and activated protein C resistance. These are the investigations which are done for non-anti-phospholipid antibody syndromes. So if it is autoimmune APLA, it's a different set of investigations. If it is non-APLA, it is a different set of investigations we are going to go ahead with. But whatever all said and done, the three pillars which are there in the management of recurrent pregnancy loss remain, that it could be an antibiotic or anticoagulant therapy, supportive tender loving care, we say TLC, and then comes the progestrogens. If you go back and think, yes, that's what we are doing for almost all of our patients. Even if the etiology is different, ultimately progesterone support remains one of the mainstay in the treatment of recurrent pregnancy losses. Let's see how this progesterone helps us in reducing the incidence of recurrent miscarriages. What does progesterone do? It prepares the endometrium for implantation, brings about the necessary secretory changes in the endometrium. There are different changes which take place at the genetic level or the gene level. Some of them are upregulated, some of them are downregulated, and that is how the endometrium becomes more receptive to the embryo and brings about the implantation of the embryo into the endometrium. Better the implantation, better the chance of continuation of pregnancy and taking a take-home baby rate. Endometrial decidualization, as I said, is important. Production of a number of endometrial proteins such as uteroglobin, PAPP, and PP14. All these are important changes which are needed for a good implantation of the embryo. Regulation of the cellular immunity. Now, as you all know, pregnancy is a shift from TH1 to TH2, right? So stimulation of prostaglandin E2 production, which suppresses a number of T cell reactions, which are again pro-inflammatory. Stimulation of lymphocyte proliferation at the feto-maternal interface, which is brought about by the progesterone. Suppression of cellular cytotoxicity from increased interleukin-2. And suppression of T cell and killer cell activity, which are again pro-inflammatory. So the pregnancy is a situation wherein we shift from TH1 to TH2. TH1 is a pro-inflammatory, while TH2 is an anti-inflammatory condition, and that is where progesterone helps for changing the balance from TH1 to TH2 when it comes to pregnancy, and that is how it prevents in recurrent miscarriages. But then the question comes in front of us, what progesterone to choose from? There are so many different preparations which are available in the market. Every day the pharma person comes to us with some kind of a preparation or the other, asking, we are better than the other. What does the evidence has to say? So let's go through the history of progesterone. Progesterone is not with us. It is not a molecule which has come in the market just now. It was first time introduced in 1936, way back in 1936. Since then, there has been steady progress in the molecule structure, the way it behaves. Like initially, it had quite a bit of androgenic activity, and later on, it started getting down with its androgenic activities. And now there was an era where we came up with something called as a natural micronized progesterone. And now again, we have come up with another synthetic progesterone called as dydrogesterone. So there are so many different preparations which are available. What to do? What to use? So when to choose the right progesterone, we have two things to be kept in mind. One, the criteria which for the doctors and the criteria for the patients. So when I say criteria for the doctors, from the doctor's perspective, we say that whatever progesterone we are going to use, it should have an evidence that it has an effective method of, it has an effect in preventing the miscarriages. So it should be efficacious, it should be safe and with least side effects, and there should be results out of it. When it comes to patients, it has to be convenient, ease of taking it. Again, it has to show us results, and at the end, availability or the cost of the drug is equally important. So there are different formulations and route of administrations which are available. We have injectable progesterone. It gives better what you can say, it brings about sufficient secretory transformation in the endometrium. And when I am in doubt whether my patient is going to take the medications or not, I would prefer to give an injectable. I give the injection in front of me and I'm sure that that drug has gone into her body, right? Then came the vaginal progesterone. Again, well tolerated. It does not go through the first pass metabolism, and therefore we want the action to be there at the myometrial level. So it delivers the drug close to the end organ. That is what the concept was when the vaginal progesterone was came into the market. And then again we shifted back to oral progesterone, because vaginal progesterone was not very convenient option for the woman to use, and therefore we went back to the oral progesterone. Again, in oral progesterone, as I said, there were two preparations: oral micronized progesterone and oral dydrogesterone. So which one to use? Should I be using oral micronized progesterone or oral dydrogesterone? In between, for some days, we also had something called as a sustained release preparation. So should I be using these sustained release preparations? Let's go through the evidence. Well, the oral micronized progesterone, it has got a poor bioavailability. Now, despite micronization, the systemic bioavailability of the oral micronized progesterone is still relatively poor, with values of less than 5%. And because the bioavailability is less, we need higher dose, up to 200 milligrams. Now, if I'm going to use higher dose, obviously the chances of adverse effects are going to be more. So high dose increases my risk of intrahepatic cholestasis and associated with drowsiness to marked sleepiness. So the optimal timing, mode, and the dose of natural micronized progesterone, particularly with sustained release formulations, is still a challenge. As I said, these SR preparations, if you see the global market, the SR preparations are not available anywhere in the world. They are available only in India, where there are not much published data. Now, few data have started coming up, but up till now, there were hardly any data which were published in relation to the use of SR, and therefore it didn't have a data to back the use of SR preparations with oral micronized progesterone. As against, if you see the oral dydrogesterone, which has come in the market now. Now, it was by only one company in the past because of the patency laws. But once the patent is over, we have got quite a few different companies with which we have availability of this dydrogesterone. The thing which is made good to us by this is that it has reduced its cost considerably, and therefore we can now use it quite often, which was a restriction when it was under the patency law. So it is approved in the threatened and recurrent miscarriages and other progesterone deficiencies. We have got more than 600 published articles and the global evidence to support that oral dydrogesterone does help in the recurrent pregnancy losses, and it is available in more than 115 countries worldwide. It has got a greater bioavailability. Obviously, if it has got a greater bioavailability, effective dose which is needed to achieve the same levels, if therapeutic levels is much less, it's about 10 milligrams. And if the dose is going to be less, obviously the adverse effects are going to be less. And therefore, it minimizes the unwanted effects of progesterone, which we don't need otherwise. Well, second thing what we have to look into is that oral micronized progesterone metabolites could be sometimes detrimental to the pregnancy outcomes. How? The higher concentrations of the circulating metabolites will oral MCP 5-alpha and 5-beta reduce pregnenolones adversely affect the pregnancy outcomes. Interference of metabolites with transcription cofactor or DNA binding action results in a lower implantation rate per embryo. So oral micronized progesterone metabolites do interfere with the pregnancy outcomes. As against, dydrogesterone is actually an immunomodulator, and therefore it shifts the cytokine balance towards Th2 cytokine production that is conducive for the success of pregnancy, and it induces an O synthesis that improves the endometrial receptivity and pregnancy outcomes. So on one hand, something which has got an adverse effect on the pregnancy outcome. On the other hand, we have got something which is better and has got successful pregnancy outcomes. So we have to think which we should be going ahead with. So what does the evidence has to say? Again, when I'm saying this, do I have some evidence to support that oral dydrogesterone is better in using recurrent pregnancy losses? This was a paper which was published in 2005 by El Zibdeh. 180 pregnant women who were 35 years of old, less than 35 years of old, with at least 3 previous unexplained consecutive marriages were included in the study. Oral dydrogesterone was given 10 milligram twice a day. Intramuscular HCG 5,000 international units every 4 days. Now, dydrogesterone, and the conclusion drawn was dydrogesterone had a significantly lower miscarriage rate compared with a control group. There was no adverse event reported during the treatment, and there were no differences in the obstetric complications. Moving on, another study which was published by Kumar et al. The objective of the study was to study the impact of administration of dydrogesterone in early pregnancy on pregnancy outcome and its correlation with Th1 and Th2 cytokine levels. Patients, women with either a history of recurrent miscarriage placed in either dydrogesterone group or a placebo group, or no history of miscarriages. How was the intervention? Dydrogesterone 20 milligrams per day from confirmation of the pregnancy till 20 weeks of pregnancy was given. What was the outcome? The miscarriage after 3 abortions was more than 2.4 times in placebo groups as compared to the treatment group. Mean gestational age increased with the dydrogesterone group, and serum IFN level was significantly higher in the recurrent miscarriage group. So the conclusion drawn was that dydrogesterone improved the pregnancy outcomes, and the outcomes were not modulated by Th1 and Th2 cytokine production. Another study which was published by Haas and Ramsey in 2013, it was a meta-analysis. 4 studies with a total number of 225 women were studies, and the data set for subgroup analysis in the recurrent miscarriage were also there. So what they did, different types of progesterone were studied. So dydrogesterone, hydroxyprogesterone caproate, medroxyprogesterone, progesterone pellets that were inserted inside within the gluteal muscle were studied, and a subgroup analysis was done. And they found that statistically significant decrease in the miscarriage rate was found when progestrogens were used as compared to a placebo group. Now, this was a study which was published by Howard Karp in 2015. Again, it was a meta-analysis of 3 studies, 2 RCTs, and 1 non-randomized comparative trial. Total number of women studied were 509, and they found that 13% absolute reduction in the miscarriage rate after the dydrogesterone treatment. Minimal adverse and side effects were found with dydrogesterone, and a significant reduction of 29% in the odds of miscarriage when dydrogesterone is compared to standard care, indicating the real treatment effect. So dydrogesterone is more effective than conservative management in enabling pregnancy. That was the conclusion which was drawn by Howard Karp in 2015. Again, Sakon published his data in 2017, a huge data, 10 randomized control trials, total number of 1,586 women were, and what was the incidence of miscarriage in women with a history of RPL after the treatment with progestrogens in the first trimester of pregnancy compared to a placebo was studied. What were the interventions done? Natural progesterone, medroxyprogesterone, again cyclopentenolone, 7-hydroxyprogesterone caproate, and dydrogesterone were given in different group of women. What was the conclusion drawn? Women randomized to the progestrogens group in all. in the first trimester and before 16 weeks had a lower risk of recurrent pregnancy loss and a higher live birth rate compared with the control group. So as compared to control, all of them who were placed into the progestogen group had a better outcome as far as the RPL is concerned and the live birth rate is concerned. What does the global guidelines have to say as far as the recommendations of dydrogesterone in RPL is concerned? European Progestin Club guidelines for the treatment of recurrent miscarriages 2015, Foxy position statement for the use of progestogens published in 2015, ISHRE guidelines on the recurrent pregnancy losses 2017. These are the three different guidelines which I have taken. The European Progestin Club guideline says that for women presenting with a clinical diagnosis of recurrent miscarriages, 3 or more, there is a reduction in the rate of miscarriage with the use of dydrogesterone. What does our Foxy position statement say? Dydrogesterone given in a dose of 10 mg twice a day till 20 weeks of pregnancy helps in reducing the recurrent pregnancy losses. And the ISHRE guideline says that the vaginal progesterone during early pregnancy has no beneficial effect in women with unexplained RPL, but there is some evidence that oral dydrogesterone initiated when fetal heart action can be confirmed may be effective. So major of the global guidelines recommend use of progesterone, recommend the use of dydrogesterone for continuation of pregnancy and reducing the chances of recurrent pregnancy losses. So to conclude, the key messages what we have to take home from this today's presentation is that the use of progestogen supplementation in reducing miscarriage rates is a well established and supported by numerous studies. Oral is the most preferred route of administration by patients compared to injectable and vaginal progesterone because of the use of its use and discomfort which is much less when it comes to oral progestogens. Dydrogesterone is the only orally effective progestogen as compared to oral micronized progesterone or an SR preparation. The use of dydrogesterone 40 mg stat followed by 10 mg twice a day has been shown to reduce the incidence of pregnancy loss in threatened miscarriages. And dydrogesterone 10 mg BID till 20 weeks of pregnancy causes significant reduction in the miscarriages or recurrent pregnancy losses. Thank you so much once again for your patient hearing. So we can use any kind of progestogens when it comes to recurrent pregnancy losses, but I have just shown you a little comparison between the micronized progesterone which was available and now the dydrogesterone which is available and which has reduced its cost because of its ample availability by the different companies. It's us to take what I should be prescribing to my patient. And I leave it to all my learned delegates. Thank you so much.
Thank you, Dr. Chaitanya, for explaining this vast topic on current trends in management of RPL. Yes, you have very nicely quoted the 3 pillars in the management of RPL, that is antibiotics, anticoagulant, and the tender loving care. And how can we forget the role of progesterone, which is very much important in prevention of RPL, and how it helps in better implantation, and how wisely we should choose the type of progesterone while handling the patient of this RPL. It's a very nice talk, and surely I know that many of us have benefited from your talk and have got enlightened. Thank you. Thank you so much.
Thank you.
Thank you so much, sir, for the wonderful talk. So we would be moving to our next session, session 3. So I would like to invite the chairperson for our next session, Dr. Vivek Virkar, sir. Sir is President Solapur Obs and Gynae Society. Sir has presented various papers at state and national conferences and also has worked as lecturer in OBGY department and BM Medical College Solapur. Sir is director at Pirkar Maternity and Nursing Home Solapur. Sir is honorary treasurer at RCOG conference and also honorary secretary 2008 to 2009 Solapur Obs and Gynae Society. Sir is treasurer 2013 to 14 at Solapur Obs and Gynae Society and has won Best Paper Prize at AICOG and AMOX during post-graduation. We welcome you, sir, on this platform. Dr. Vivek, sir, thank you for joining us, sir. Our next chairperson is Dr. Vinod Shetty, sir. Sir is President, Akluz Obs and Gynae Society, 23 to 24. Sir is practicing obstetrician and gynecologist at Shetty Maternity Home, Akluz, since 20 years. Sir is Director and IVF Consultant at Akluz IVF Center and having a special interest in IVF, sonography and high-risk obstetrics. We welcome you on this platform, sir. Thank you for joining us. Now, I would like to hand over the session.
Thank you, madam, for your kind introduction.
Yes, thank you, sir. So I would like to hand over the session to our chairperson for introduction of our next speaker.
Thank you for your kind introduction. Now, good evening, one and all. So it gives really both honor and privilege for me to introduce Rakhi Singh, madam. Actually, she doesn't need any introduction. I formally introduce her. She's director at Avalon Clinic, Maternity Fertility at Noida. She's chairperson of Endocrine Committee of FOXI, vice chairperson UP State ISA. She's peer reviewer of Journal OBGYN India, ICOG Governing Council member elect to 2024-2025. She has been winner of many awards like DC Datta Award for publications, the CS Dawn First Prize, Wonder Foxian Awards, Gira Awards, and she's written various chapters in books, Foxy Focus, of course.
Thank you, sir.
So,
let's move ahead. I think there's no need to waste much time.
Yes, madam. Over to you, madam.
Thank you, sir. Thank you, Dr. Vivek. At the outset, I bring you greetings, me being as a chairperson of Endocrine Committee of FOXI. I bring you greetings from the President of FOXI, Dr. Rishikesh Pai, Secretary General FOXI, Dr. Madhuri Patel ma'am, and the chairperson for my Endocrine Committee is Dr. Gitendra Sharma. And apart from that, I would like to thank Bhopal OBGYN Society and the Bhopal Menopause Society for their collaboration with the Endocrine Committee for their second series of Symbiosis in RPL, which we are doing it today. And thanks to all the delegates and the esteemed faculty who have taken out the valuable time for this webinar and to understand the RPL, everything about RPL. And there were two lovely talks which has dealt at length about the whole endocrine causes and their unexplained, and then the progesterone, how it has to be given. Actually, my talk was supposed to be there as an overview in the beginning. Due to some other reasons, it got shifted off. And though Monica and Randhir were very close to heart, and they formally invited me, so I could not tell no. And it was a pleasant thing to be associated and be here for this webinar. And I won't take much time for everybody for this talk of mine, which is on endocrine causes of RPL. Basically, we've been talking about RPL all this while. And there are great many problems. Whenever the mother loses a child, it is a huge loss to the mother. The gestational age doesn't matter. The footprints of the little one is already left its print on the heart of the mother, which is very important for her. And a repeated RPL, that is repeated pregnancy losses, would definitely have a trauma to her in the mindset. There are many turmoils which are happening for these patients. And I'm going to talk only of a small chunk of the causes of RPL, that is endocrine, because if we start talking about the RPL per se, it is a full 3-day conference, full day, and there it would be. What is the theory which accepts versus rejects? Basically, according to the Sir Peter Medwar, he says that the human mind treats a new idea the same way body treats a stranger protein, whether it rejects it or accepts it. Same thing happens with the pregnancy, the embryo which wants to get established and grow inside the womb. let's redefine and classify RPLs. Basically, which everybody is told, I'm not going to repeat much. There are RPL cutoffs, whether it is 2 or more failed pregnancies, or if it is the age group of more than 35 years, and the investigation needs to be done even after one miscarriage, and need not wait for 2 or more clinical pregnancy losses. Let it be the abortion, the one abortion or the 2 or the 3 or more abortions in this. Mostly occurs within 12 weeks of conceptions, these RPL, and more than 50% are unexplained in these categories. Primary or recurrent pregnancy losses refer to the couple that have never had a live birth, and a secondary RPL refers to those who had a repeated losses following a successful pregnancy. Either it is up to 4 weeks, that is before the pregnancy test is positive, that is pre-implantation, or it is post-implantation, then it becomes the primary or the secondary pregnancy losses. Here we're going to deal about only the endocrine factors. And per se, these endocrine factors, when you're talking, it is a huge number. 1/5 of it would be the endocrine, that is to the tune of 20%, which is very important for us to understand and give an importance to it. A detailed history is one thing, the key for the recurrent pregnancy loss patients, which has to be understood by these patients. The past obstetric history, if the patient has bought all the papers, we need to understand what is the duration when the abortion has occurred, whether it was full term or the second trimester or the first trimester, whether it was early, whether the cardiac activity was seen or not, and whether the fetus what was aborted was a malformed fetus, or the term pregnancy at the time of abortions, or the location of the fetal heart, or it was an embryonic fetus which was there. And these all detailed documentation of RPL will help us to understand whether the patient at times is communicating to us, whether it is a stillbirth, or it was communicating to us whether it was a second trimester. We need to cater the whole basket of the patients and understand. There are many environmental factors and lifestyle, as our colleague has explained us in the initial first talk, that the environmental factors play a major role and is diagnosed by the history itself, whether the patient is smoking or anesthetic gases or the toxins and the chemicals, if she's inhaling, that could be one of the causes for the recurrent pregnancy losses. Or the high-risk lifestyle factors like the obesity and a higher BMI or a very low BMI. Any extremes of these could also be the cause. The daily caffeine intake being more than 300 micrograms, alcohol consumptions, and the use of NSAID if she's using it regularly because of any XYZ reason, that could also be triggering for the recurrent pregnancy losses. Talking about the endocrine causes, there are various causes in endocrine system which can be affecting, can be the result for the RPL. That could be the polycystic ovarian disease, which is a huge big burden in the chunk of the endocrine system, can be 20 to 40% of it. Under the endocrine causes, either it could be the uncontrolled diabetes or the luteinizing hormone which is increased, or the hyperandrogenism, or the luteal phase defect, which could be to the tune of 23 to 60% and has been brilliantly covered to a greater extent by Chaitanya. Hyperprolactinemia, thyroid dysfunctions, ovarian reserves, and vitamin D deficiencies, all these could be the part of the endocrine causes. The recurrent pregnancy losses in polycystic ovarian disease and the role of homocystinemia and insulin resistance is seen. The RPL is found in 1 to 5% of the couples desiring pregnancy. A plethora of factors have been addressed that are associated with the pathophysiology of RPL in PCOS. And the metabolic derailment of the O syndrome, like obesity and insulin resistance, have been implicated as the individual risk factors for RPL. The recent evidence suggests that another metabolic component of homocystinemia to be the frequently associated in these subjects with PCOS. That is what we have understood till now. So that has to be treated and taken care of. The recurrent pregnancy losses and hypersecretion of the LH, which is more, the mechanism by which LH exerts an adverse effect is not clear. Raised follicular phase LH may cause premature resumption of meiosis.
Production of physiologically aged oocytes are there in these RPL PCOS patients. LH causes endometrial defect and suboptimal implantation is seen. LH causes increased secretion of the androgens from the ovary, and because of which many a times these patients have RPL happening. A diabetic woman are probably no more likely to miscarry than the non-diabetic woman. The diabetic woman with raised glycosylated hemoglobin concentration in first trimester are at increased risk for RPL. Diabetic patients should be euglycemic before attempting for pregnancy. That is why most of the PCO patients, we try to put them on metformin or something and check them up with the OGTT 75 grams so that they are in the euglycemic state and before they plan up for the pregnancy. Hyperprolactinemia is another entity which causes short of the luteal phase, and prolactin interferes in the normal activity of development of the placenta. Thereby, the prolactin levels are often measured for the assessment of the ovulatory dysfunction. Many a times there is a certain amount of ovulatory dysfunction when the hyperprolactinemia is there. But in spite of that, some patients do conceive. If they've conceived, the pregnancy doesn't move ahead. It could be because of the developing placenta, which is at fault, and prolactin disorders are possibly associated with PCOS, luteal phase insufficiency, stress, and obesity. Common in RPL, luteal phase insufficiency, inappropriate corpus luteal function is formed because of the production of the progesterone, which is inadequate for the endometrial preparation. Progesterone helps in the implantation and the pregnancy to move ahead. Progesterone induces secretory changes in the endometrium. Progesterone has an immunomodulatory effect, and increased production of progesterone induces blocking factors and suppresses the natural killer activity and increases the Th2 response. Because in these RPL patients, the Th2 response is always decreased. That could be one of the reasons where we can understand that the LPD is also one of the cause for it. This suppressive effect favors implantation and progress of the early development. Basically, what is the luteal phase LPS? That is, numerous studies have confirmed that the ovarian stimulation used in controlled ovarian hyperstimulated cycle is associated with luteal phase insufficiency, and it represents administration of the drugs to support the process of implantation because there is some amount of dyschrony, and the supplementation is crucial between the disappearance of the exogenous HCG and administered final oocyte maturation and the rise in the endogenous HCG during the early implantation. So that is a window where we need to supplement progesterone for these patients of ours. And this Cochrane review, which is little older, of 2012, it also suggests that it is a significant effect for the favor of progesterone. Let it be whatever progesterone mode what we are using, and progesterone has to be supplemented for these patients. When the progesterone has to be supplemented is another second question which comes to our mind, that progesterone supplementation has to be started before the beta HCG is positive. And if it is started after the HCG, which is beta HCG, which is positive, not the benefit is not to that extent. So always remember, before the HCG is positive, we need to supplement these patients with the progesterone. Basically, what all testing has to be done in the purview of endocrine causes. Whether we test for the luteal insufficiency? No, we don't require to test luteal insufficiency. If ovulation has occurred and we documented that when the periods are there, then we come to know on ultrasound monitoring itself that the luteal phase insufficiency is done. Androgen testing is also, because hyperandrogenemia, they are clinical signs. We can come to know with the hirsutism, the acne, we come to know that the patient is having hyperandrogenism, and per se the testing is not required. LH testing, PCO patients can be diagnosed clinically, so that is also not required. Measurement of homocysteine and the plasma level is also not routinely recommended in patients with RPL. The assessment of PCO syndrome fasting insulin and fasting glucose is also not advised. Ovarian reserve testing is not advised to these patients if the patient is ovulating correctly, and if the patient is not ovulating correctly, then we can go in for the ovarian reserve testing, or the prolactin testing also can be done for any of the infertile patients. And is there any relationship between thyroid and RPL? Let's understand that. Yes, the thyroid hypothyroidism, if the patient is having the TSH level, cutoff levels have to be maintained according to the trimester wise. Let it be the first trimester, the TSH level, what we have to maintain is the upper limit should be 2.5. The second and third trimester, the TSH cutoff limit is 3, what we need to maintain. And in hyperthyroidism, it is rarely independent cause of RPL, and subclinically, if it is present RPL, and with hyperthyroidism, there is no need of treatment to be given. If it is overt, treat the targeted levothyroxine in the upper middle range, or the FT4 has to be taken into account. If the T4 is low, the diagnosis is overt hypothyroidism, which can impair the infant's neurocognitive development. There are also increased risk of premature births, low birth weights, and miscarriages. These overt hypothyroidism must be treated for these patients. Let it be whether it is the subclinical hypothyroidism or the overt hypothyroidism, that has to be treated for all these patients. If the TSH is higher than the T4 is normal, then the diagnosis is of subclinical. The range is, if it is 2.5 to 10, then it is subclinical. And if it is above 10, then it goes to the overt hypothyroidism. And in this case, check also for the antithyroid peroxidase antibodies. And the women who are antibody positive should be treated also for these patients. Thyroid autoimmunity and RPL, the prevalence is around 5 to 10%. And association of the major studies shown, a few larger studies show that no association. Some studies correlate with the titer, unlikely to be the cause. And thyroid and autoantibodies serve as a peripheral marker for abnormal T cell functions and not necessarily about the abnormal pathogenic problems. Euthyroid state, as I had told earlier, with autoimmunity, there is no role of IV, IgG or levothyroxine or the selenium. TSH every 4 weeks need to be repeated in the first 20 weeks till the time the threshold level is maintained according to the trimester wise, whenever the thyroid, the patient is detected for the hypothyroidism. And thereafter, once the plateau is attained, the patient is within normal range, do check the patient again at 26 weeks and again at 32 weeks of gestation and just before delivery. To summarize, the thyroid screening, that is TSH and thyroid peroxidase antibodies, is recommended for the woman with RPL. Abnormal thyroid stimulating hormone and thyroid peroxidase antibody levels should be followed up by thyroxine testing in women with RPL. In unexplained, as our dear friend has already told, the tender loving care, even after 3 miscarriages, is important. And even the chances of success without any treatment is approximately 60%, except for women with antiphospholipid syndrome and the thrombophilia, which have a success rates which are a little lower. But all the other patients have a good success rate if the tender loving care is given, which is very well explained by our dear friend Supriya also in her talk. There are a few points to remember. That understand the possible reason for the miscarriage, which is very important. Extensive diagnostic workup with a history taking has to be done for the successful treatment and an outcome for these RPL patients of ours. The future trends. Accurate diagnosis is required. Stop looking for panaceas. First, determine if the embryonic or the maternal cause for RPL is there. From evidence-based to tailor-made protocols have to be given for these patients of ours. There are various questions with our patients in their mind which will be running around when they come to the doctor. What is the cause? They want to know about all the questions and answers for that. what would be the prognosis, what would be the treatment for it, or the investigation what the doctor is going to give. As the patient is having their questions in their mind, the doctor also has 110 questions, whether it is immunopotention or the anticoagulants have to be given, or the correction of the uterine anomalies, or the hormone supplementation has to be done, or the ART treatment has to be given for these patients of ours. Remember, the woman who had at least one live-born infant has a good prognosis, and with no prior fetal loss, the recurrence risk is 12% for the next pregnancy, and with one prior loss, the recurrence risk is 24%. 2 prior loss, the risk is 26%, and 3 prior loss, the risk is 32%. As the losses number increases, the risk for the next pregnancy for the RPL also increase. And the women who have not had at least one live-born infant with 2 or more fetal losses, recurrent risk for the next pregnancy is around 40 to 45%. I would like to end by a quote by Charles Darwin. It is not the strongest of the species that survive, nor the most intelligent that survives. It is the one that is most adaptable to the changes. Do make through. Tender loving care, even after 3 miscarriages, have the chance of success without treatment is approximately 60%. Do remember that, and that is required. And the counseling with the couple is required, that you need to maintain your calm and have a sympathy and empathetic feeling towards the patient.
Thank you, madam.
Thank
you, madam. This was very informative and enlightening speech which you have given. You have elaborated all the causes of endocrine causes of recurrent pregnancy loss, and how the chances of recurrent pregnancy loss increases with per pregnancy. And you are relatively told everything about the investigations which are needed for the causes of various endocrine causes to rule out the diabetes, hypothyroidism, luteal phase defect, PCOS, hyperprolactinemia. So this was very nice and informative speech. Thank you so much.
Thank you, Dr. Vivek.
It was a very nice talk, madam, and I'm so glad the sequence of the lectures actually it became, better. First, Dr. Supriya took all that aspect of unexplained, and then Dr. Chaitanya talked about evidence-based medicine focusing on progesterone, and now you have beautifully wrapped it up with the whole.
It was just a clinical overview. Basically, it was a clinical overview. My talk was more towards a clinical end. And
it was an excellent talk, and all the 3 talks were excellent, madam.
Yeah.
Very, very nice. Very nice. Thank you so much, ma'am.
Thank you. Thank you.
Thank you, ma'am. So we would be moving to our next session, panel discussion. Slide, please. Yes. Yes. So for our panel discussion, the topic is evidence-based treatment algorithm in RPL, and I would like to invite our moderators. Slide, please. Dr. Sandeep Nikhande, sir. Sir is director at Lifespring Hospital and Parvati IVF, Nagpur, and also consultant laparoscopy and pelvic surgeon. Sir is president-elect Nagpur Obs and Gynae Society, member Foxy Endoscopy Committee 22 to 23, invited member Foxy ART Bill Cell, invited member Foxy Violence Against Doctors Cell. Sir has won Foxy Dr. C.S. Down Award at AICOG Kolkata 2023. Also a winner of Dr. M. Rohtagi Award for Endoscopy in 2020. Sir has been organizing secretary IAG Gynecon Laparoscopy Live Workshop in 16 and 22. Sir has performed more than 14,000 laparoscopy procedures and has been operating faculty at various national and local live operative workshops. We invite, thank you, sir, for joining us as moderator on this platform. Our next moderator is Dr. CV, please. Dr. Pragati Vasant Khalatkar, ma'am. Ma'am is a gynecologist and obstetrician having more than 28-year experience. She is director Khalatkar Hospital for Mother and Child. Ma'am is Secretary Nagpur Ops and Gynae Society. She's Principal Co-Investigator for Core Research Studies and Trial of Covaxin. Past Secretary VP Menopause and Society Nagpur. Past President NARCHI Nagpur Chapter. Past Secretary AFWI. She's the National Coordinator Sat Sat IAP Foxy Initiative. Also Associate Member RCOJ and Member of Sexual Committee Foxy. Ma'am is past President of Lions Club Metro. Ma'am has been Organizing Secretary in so many conferences and Joint Organizing Secretary and National Conference of NARCHI and AMSCON. Ma'am is recipient of NOGS Gold Medal Award in 2019 and also Wonder Foxian Award, MS Signature Award, Khandwala Best Paper Award, so many awards to ma'am's credit. And ma'am has presented papers at various conferences, having a special interest in high-risk ops and balloon tamponade in OBGY, and has been invited as national and international faculty in various conferences, and also under her direction and lyrics for Pedicon song AICOG Amok song. We welcome you, ma'am. Thank you so much, ma'am, for joining us. Dr. Pragati, ma'am. So I would also like to invite our panelists. Our first panelist is Dr. Ruzita Fuke, ma'am. Ma'am is Associate Professor, Department of Ops and Gynae, GMCH Nagpur. She is also faculty of MUHS Nashik and routinely invited to serve on the examiner panel for OBGYN examination. Ma'am has done so many trainings in colposcopy, fetal medicine, fellow of Indian College of Ops and Gynae and Indian College of Maternal and Child Health. Ma'am has received late Dr. Rangilal Singh Memorial Award, late Dr. Sundarbai Kunnawar Memorial Award, Dhanvantri Award, and so many awards to ma'am's credit also. Ma'am has delivered prestigious UPA NOGS oration, and also she is editor-in-chief of a book on menopause and has presented various papers and various conferences. We welcome you, ma'am. Dr. Rujita, ma'am. Our next panelist is Dr. Mayuri Kelkar, ma'am. Ma'am is consultant at Narayani Hospital, Nashik. Professionally trained obstetrician and gynecology, ensuring high standard of competent care for wide variety of patients with diverse needs, having area of interest in high risk of complicated delivery and so many. And also, ma'am is currently Secretary of Nashik Ops and Gynae Society, like member of Nashik Ops and Gynae Society, and Joint Secretary of Nashik Ops and Gynae Society in 22 to 21. We welcome you, ma'am, on this platform, Dr. Mayuri, ma'am. Thank you for joining us, ma'am. Next panelist is Dr. Meena Gunjotikar, ma'am. Ma'am is an alumni of VMGMC Solapur. She's consultant ops and gynae at Gunjotikar Nursing Home Solapur. Also consultant obstetrician at SSNJ Ayurveda Hospital Solapur, and has already ma'am has participated in so many social activities, having a special interest in NDPH. Thank you, ma'am, for joining us. We welcome you, ma'am. Next panelist is Dr. Manisha Vasade, ma'am. Ma'am is Secretary Chandrapur Ops and Gynae Society, past Treasurer and Joint Secretary of COGS, past Secretary of IMA Women's Wing, life member of PCOS Society of India, and member of HIV Committee Foxy 22 to 24, having a special interest in women's health and education. We welcome you, ma'am. Dr. Manisha, ma'am, thank you for joining us. Next is Dr. Shraddha Paidkar, ma'am, is not joining us today because of some unfortunate circumstances. Next is myself and Dr. Monica, ma'am, also are the panelists in this panel discussion today. So
we are the unprepared panelists.
Yes.
Wild card entries.
I would like to hand over the session to our moderators.
Thank you, Dr. Purnima. We are really very pleased to be on this Symbiosis series of webinar. Today, Foxy Endocrine Committee, Bhopal OBGYN Society, and Bhopal Menopause Society have thought of a very unique topic, a topic which is for conferences which we are going to do in this 3 hours. Previous speakers have been so much apt and so perfect in their deliberations. And now we are here, myself and Dr. Sandeep Dikhade, my co-moderator. We will be running this panel. So I'm thankful to all here present here, especially my thanks to Dr. Anita Srivastava, Bhopal OBGYN President, Dr. Shabana Sultan, Dr. Shashi Srivastava, Bhopal Menopause Society, Dr. Shraddha Agrawal, Secretary OBGYN Society, my dear friend Monica Singh, Randir Singh, and Purnima Tiwari for taking this initiative, and definitely not on the top, Dr. Rakhi Singh,
Endocrine Committee Chairperson. Ma'am, your talk was excellent and really you put in such a good efforts. Now we, Sandeep and myself were just thinking, what are we going to do in this panel? Everything has been so well covered. So moving ahead, RPL is just a clinical challenging condition with lots of psychological trauma associated with a lot of no evidence, less evidences and a lot of controversies. So it's very difficult for the plate for us as a treating obstetricians and even for the patient. So here we are going to present about what is RPL and the case-based discussion. Sandeep, you can just share the slides.
Yeah, good evening, everyone.
Yes, slides are visible, Dr. Sandeep. You can make it full screen.
Yeah. Perfect?
Yes.
Yeah. So thank you, this MOC and Bhopal Society for giving us this opportunity for this wonderful panel discussion. All those previous speakers have made our job easy, and sometimes I feel like it has become more difficult now. So which type of questions we should ask to our esteemed panelists? But then we have to go ahead with this, and we're starting with our presentation on evidence-based treatment algorithms in recurrent pregnancy loss. So this is a quote from the Mrs. US President Michelle Obama, and when she had undergone an abortion, she said to an interview that I felt lost and alone when I failed because I didn't know what the common miscarriages are, and I didn't talk about it. We sit in a pain thinking that someone had broken us. These are the few hurtful comments after miscarriages, that the timing wasn't right. Everything happens for a reason. At least you know you are able to get pregnant, and at least you are already have done, or just try again. There is a quarrel between the couples, and they were just dreaming of a beautiful baby, but a demon is there sitting on it. That is the RPL demon, and all our esteemed panelists will kill that demon and will assist our panelists, will assist that couple to get a healthy baby. So all these are the esteemed panels. I welcome you all the esteemed panels. So starting with the first question, which patient should be labeled as a RPL patient? So we'll ask to the Dr. Purnima, madam.
Sir, according to the recommendations and guidelines, the patient who had the 3 or more than 3 miscarriages before 20 weeks of gestation, we call that as recurrent pregnancy.
So when will you start interfering with a patient who's coming to OPD?
Yes, ma'am. Yes, if patient is coming to us and she's more than 35 years, I would like to start investigating after 1 miscarriage only. Correct. And then yes, we would do the initial workup and we will see what are the risk factors. Is she having obvious risk factors for RPL or not? And yes, after 1 miscarriage, I would like to investigate.
So what is the definition of RPL you consider in your practice?
Anyone can take the question.
Yeah, Dr. Manisha.
Yeah, so a patient who is having 2 or 3 consecutive miscarriages in a life, and if that is before 20 at or before 20 weeks of pregnancy, and when the fetal weight is less than 500 grams, then we call it as it's a proper definition of RPL. Is like 2 or 3 consecutive pregnancy losses before 20 weeks of pregnancy, and when the fetal weight is less than 500 grams, then we call it as RPL.
Yeah, perfect. So this RPL is defined as in the SEOG criteria, more than 2 consecutive failed pregnancies before 24 weeks of gestation, and in UK they consider it as more than 3 consecutive early pregnancy losses. But the ASRM defines RPL as a loss of 2 or more failed clinical pregnancies. Then there is another definition, primary RPL and secondary RPL also.
Yes.
So which pregnancies are not included in the RPL? Dr. Rujuta?
Sir, Ruzuda ma'am will be joining in 5 minutes.
Okay. So Dr. Mayuri?
Dr. Mayuri is there?
Dr. Meena?
Yes, sir. I'm there. The pregnancies which are more than the age of viability or more than 20 weeks or more than the 500 grams of abortus, which are not included in RPL, what I think.
Will you include ectopic pregnancies or a molar history of molar pregnancies?
No.
Many times some pregnancies, they come out to be positive and biochemically they are positive. Then also we don't count them in RPL.
Yeah. Okay.
So this ectopic, molar pregnancy and biochemical pregnancies are not included in the RPL. So how much is the prevalence of RPL and what are the etiologies of RPL? Anyone, Dr. Monica?
The prevalence of RPL, I think it has been beautifully, described in the talks. It is roughly about 1 to 5%. But if you take the diagnostic criteria as ASRM criteria of 2 consecutive pregnancy losses, then the prevalence just doubles. It can go up to 5 to 9%. It's just the criteria. When you have 3 consecutive losses, it's about 1 to 5%. But if you have got 2 consecutive losses, then it may go up to 2 to 9% or 10%. And the etiology of RPL, we have seen that pie chart. A large chunk of RPL, nearly 40 to 50% sometimes is unexplained, but the factors which are explained are definitely a large chunk is genetic factors for which investigations are ongoing, endocrine factors, that is why we are with the FOXI endocrine committee now, anatomic factors which are easy to diagnose, easy to treat, infections which is plus minus in the etiopathogenesis as well as the diagnostic and therapeutic criteria, autoimmune, which we know as well as we don't know. And as I told you, a large chunk is the inherited and acquired thrombophilias, which we are combating slowly and slowly.
Okay. So these are the few risk factors and pathologies, that is maternal age, uterine pathologies, genetic anomalies, infectious agents, endocrine disorders, thrombophilia, immune pathology, vitamin D deficiency, and others. And then another is the last one is the unexplained. So do you really think that nearly 50% of cases have unexplained etiology, Dr. Monica?
No, I think this is actually a pie chart from maybe 5 or 8 years back, where 50% chunk was considered unexplained. But nowadays, our diagnostic criteria are more accurate and more vast. Like we can detect the anti-TPO antibodies very easily. That test has come under reach. Nowadays, we are doing PGT. We are doing not only karyotypes, but we are also doing, the genomic hybridization. We are going for NGS sequencing techniques, Sangers. So many things which were earlier unaccessible to us, they have now come to us with definite diagnosis. So I predict that in the next decade, the bracket of unexplained will reduce to just 25%, if I'm not wrong.
Yes, madam. Yes, you are near to that answer. And a paper published in 2018 by the ISHRE states that a recurrent pregnancy loss evaluation combined with the 24th chromosomal microarray miscarriage tissue provides a probable and definitive cause of pregnancy loss in over 90% of the patients. So we are a handful of causes we are just left out, and that unexplained category will be reduced to only the 10%, 5 to 10% now. So as the Bill Gates said, it's fine to celebrate the success, but it is more important to heed the lessons of the failure. So let our panelists be faced with these cases, and let's then dig the cause of this case. So I'm stating this first case to Dr. Manisha.
Yes, sir.
So this is a 37-year-old gravid through abortion presented with bleeding per vaginum since 1 day. She got married 2 years back, and she had 2 abortions. There were no D&E done, and this time the ultrasound TVS done, which showed 8 weeks missed abortion. On menstrual history, she had regular menses and doesn't report any dysmenorrhea or menorrhagia. There is no intake of any excess alcohol or smoking, and there is no family history of consanguinity. In the past medical history, there is no history of diabetes, thyroid, or any rheumatological diseases. The body mass index is 23, and on examination, clinical examination, there nothing abnormal was detected. So my first question is whether this history is relevant to ask in each and every patient, Dr. Manisha, and what are the different points you will ask during taking the history taking?
Sorry, since she is an elderly patient with a history of previous 3 losses, which were in the first trimester and in the early first trimester losses. So, since the history is already taken about so many things like endocrinological history is negative, her BMI is normal, and her menstrual cycles are normal. So, most of the things are ruled out already. So, we'll have to ask her about, since most of the things are ruled out, we'll have to investigate her regarding other causes which are not mentioned over here, like the early pregnancy losses are more commonly seen in chromosomal conditions, like genetic factors can be the cause here for her pregnancy losses. So we'll have to investigate her regarding her chromosomes, like the parental karyotyping can be done in this case, and then we'll have to see whether the parental karyotype is normal or not, and also the POCs can be checked out, like we can investigate the products of conception by doing a microarray or a fish technique, or the newer techniques whichever are available now, and the full RPL workout can be done in this case.
So now this patient, you did the DNC and you got the product of conception, and this karyotype, this chromosomal assay report says that it is a aneuploid type of chromosomes. So what will be your next step?
So in this case, it's an aneuploidy. So we'll rule out other. In aneuploidy, we'll suggest the parental karyotyping we'll first do, and
yeah, we'll go for this. We can suggest them to the PGT or PGS in the next future, or you can send that patient for the IVF also.
Okay.
And if there is unbalanced translocation, you can go for the parental karyotyping, and you can offer the PGT test in the.
Yes.
Sir, can I add something? I
Yes,
can add
ma'am. Yes, ma'am. Yes, ma'am.
What I wanted to, because I did very extensive webinar on genetics also, what I understood was simply that if these translocations or inversions are unbalanced, then these are also present probably in the parents. So that is the time you have to assess the parental karyotype. Otherwise, routine parental karyotyping is not recommended unless there is no product of conception.
Right.
The product of conception is not available for examination, then parental karyotype should be done. But if it is unbalanced translocation, you might find some problem in the parental karyotype, and counseling has to be done for future conception. But if it is a simple aneuploid karyotype, then the patient can be given tender loving care and suggested to go for pregnancy. There is a very high chance that this problem will not repeat in the future conception.
Coming on to our basic tool, if you do the ultrasound, so watch which different.
Hello, Sandeep
Hello.
sir, I have a question. So most of the Sandeep sir, Rujuta here.
Okay.
Yeah.
Sir, I have a question. Sir, if we simply advise them by giving facts and figures that this is aneuploidy and we don't need to do go for parental karyotyping, right? So most of the time the parents are so anxious that they are not ready, and many a times they come to us with a report of parental karyotyping. So what I meant to say is, we sometimes, even if we counsel them, it's not enough for them to, get counseled, because they are all anxious parents, anxious patients. So they ask us, and most of the time they come up with these reports.
So can I add something? Can I add something here, sir?
Yes,
Again,
yes, yes.
sorry for interruption. Sorry for interruption, but I wanted to give
No,
some
go ahead.
that remember a time, Dr. Rujuta, when everybody, but you are young, you must not have seen Pragati, and I must have seen everybody carried a torch report.
Yeah,
Though
yeah. Even now they can.
it was not indicated, not recommended, totally foxy had done away. Everybody still is carrying torch reports, you know. So similarly with parental karyotype is only 3200 or 3500. If they wanted to get it done, and if it is lifting a weight off their mind, let it be done. Doesn't matter. But you have to give the evidence. What is evidence and what is not evidence, and write it down on your paper that we have not advised, but patient is insisting on karyotype.
Right.
It is okay. It is okay.
Right. Okay.
It's not very expensive also. Yeah. Thank you.
Yes. So what is your probable diagnosis, Manisha, in this case?
So in this case, it was mostly a it was mostly a aneuploid. I mean, genetic cause for.
Yeah. So is it necessary to do
Chromosomal or genetic
chromosomal
cause.
evaluation of the POC?
And we'll have to do the evaluation of the POCs. Yes.
Dr. Mayuri?
Yes.
As such, POC chromosomal analysis will just reassure the patient.
Right.
Because we know that aneuploidy would be the most probable diagnosis in this.
So few of us will say that it is unnecessary or expensive, but
it is expensive, but to just reassure the patient that this was caused because of the aneuploidy itself, not because of any other.
Baby is chromosomally abnormal, then she will be more happy, and next time she will be mentally more prepared.
So, sir, for the next pregnancy, Sandeep, sir, should we advise her to go ahead with next pregnancy, or she should do ART with PGT?
No, that depends on the madam aneuploidy or this unexplained translocation.
So, sir, what is your message?
Yeah.
Is your message?
We'll come to that later.
Okay.
Keeping the best for the last, sir.
Yes. So the genetic evaluation will, if it comes to abnormal, then genetic evaluation of the parents, and you should proceed with that. And if it is normal, then think about the other causes of the RPL. So which is the best method of chromosomal evaluation as per your experience, Rajita?
Sir, I think, sir, whichever the patient, whichever method the patient affords, fishes, I think, is done most of the time. Right. But a complete chromosomal evaluation will be better.
Yeah. So we got these 4 types of different evaluation of this, and which you recommend, Monica, madam?
Sir, again, I will quote something from the genetics webinar. We talked with very good geneticists in India. So they said, you go into a library and you open a book. So when you take out the book from the shelf, it is the karyotype. Karyotype is screenshot of the chromosome. It is the basic thing. If you take out one page out of the book, that is CGH. Comparative genomic hybridization, which is more accurate. But if you want to read a word from the line of the book in a sentence, you have to go for sequencing. So the most accurate is sequencing, actually NGS, but it is most expensive also. Right. But it has got some limited tests. NGS can be done for limited, CGH can be done for limited. Karyotyping is for the whole chromosome, but will not give you more information. So basically now we have to go for, sir, after fish, we have to go for CGH and NGS if we want to come to good conclusion.
Yes, madam. Even this history in the latest guideline, they also stated that this CGH, this chromosome macro is the best method of evaluation of the chromosome, and followed by karyotyping. But best is NGS, but it is quite expensive also. And as Madam elaborated the limitations, so macro is the best method of chromosomal evaluation.
Sir, there is something Sanger sequencing also nowadays, Sanger sequencing, which is, I think, NGS, part of NGS only, some technology of NGS.
Okay.
So Sanger sequencing is being easily done in metro cities nowadays, which is again very specific form of NGS, or maybe it is one technique. I have to still study about it. So the problem is, sir, कितना पढ़ाई करेंगे?
We'll send the sample with the for the microarray. As of now, so you decided that you go for this chromosomal microarray or NGS. Then how will you collect the sample, Dr. Manisha?
So we would like to collect the sample in a sterile in a bottle with a normal saline, and the abortus is collected in a sterile tube, and it is collected aseptically through hysteroscopy, or and it is then along with the sample, maternal blood is also collected, and it is sent for for the this investigations.
Dr. Purnima, do you collect this POCs through hysteroscopy in your practice?
No, sir. No.
Okay. Anybody in the panel? They do collect this? I think it is simple D&D will suffice for this.
We can
right?
aspiration say we get the POCs directly without it going
in MVS saline. Yeah.
Yeah. Okay.
MVS is are better, right?
Yes.
So we have to send it in a normal saline.
Yeah, this is the algorithm. If there is a first miscarriage, there is no action to be taken. If there is second miscarriage, obtain the POCs and send it for microarray. If it is aneuploidy, then no further evaluation. If it is unbalanced or chromosomal unbalanced translocation or Robertsonian translocation, then you perform the parental karyotypes. If it is haploid, then go for the if it is euploid, then go for the RPL workup.
Sir, I have one question here. Sorry to interrupt. Like, if we are having a product of conception or abortion, like we can send it. But if we are having like second trimester abortions, if we are having like a fully formed fetus around 15 to 16 weeks, so what exactly tissues to be sent of that fetus for this genetic analysis?
Yeah, we send it for this chromosomal analysis, no?
Skin sample, sir. Skin sample sent. Sample of which part of the body of the fetus? Skin biopsy.
Yeah, but skin. You can take the skin.
Okay, what do they? I have never sent, so I don't know, Purnima.
Ma'am, we used to send it from like from both the ear cartilage and one from the thigh and one from the buttock. So 4 tissues we used to send around 1.5 centimeter, 5 mm. I mean 0.5 centimeter by 0.5 centimeter. But we were not sure. I'm not sure about it, but we used to send it like this only.
Right, that's a great input. Thank you, madam.
Thank you.
So what advice will you give to couple, Dr. Manisha?
So we would like to reassure the couple, especially the elderly couples, and the male part will ask what previously has been mentioned. Tender loving care is the best encouragement and reassurance to the patient. Also, the male part, we would like to improve the lifestyle advice. We will have to give the male part, like, and antioxidants are to be supplied before conception, like at least for 3 months. Then if he's having some addiction like tobacco or alcohol or like that, then we'll have to ask him to quit those addictions. And regarding the female part, if she's having any medical issues like diabetes or uncontrolled diabetes or hypertension or hypo or hyperthyroidism, that has to be treated. And also her BMI, if she is more obese, more than 25 her BMI is, then we'll have to ask her to control it, also reduce her weight. Regarding her lifestyle, we'll have to ask her to improve the lifestyle also, and in such way we can counsel the couple.
Yes, thank you. Monica madam, this ISRA guidelines states that you have to avoid the excess of alcohol. Means how much alcohol you can permissible during pregnancy?
Sir, 5 drinks in a week.
Okay. So at least 1 drink in a week.
I don't know how much is in 1 drink because myself and my husband are teetotalers. Okay. But more than 5 drinks in a week is harmful. So they must be having 1 drink per day.
that is negligible.
Actually, these countries are having a lot of social drinking also. So social drinking is the problem. Once they go, I think the culture is such that like they don't eat anything. They only drink, sir.
So the previous speakers have covered this folic acid supplementation and progesterone supplementation. So we will not discuss about this.
But I know about caffeine. Caffeine should not exceed 200 milligram in a day.
Okay.
It should not be more than 200 milligram of caffeine in a day. So if you are going to have your coffee very strong or black coffee, you should be very careful.
Yeah. So to conclude, this ISHRE recommendation for this case is genetic analysis of the pregnancy tissue is not routinely recommended, but it could be performed for explanatory purpose. For genetic analysis of the pregnancy, microarray is recommended based on the reduced maternal contamination effect. And parental karyotyping is not routinely recommended in couples with RPL, but it should be carried out after individual assessment and risk, as was pointed out by Dr. Rujita. Coming on to the second case, Dr. Rujita, you will take. So she is a case of 30-year-old Sita, married since 4 years with spontaneous abortion of 14 weeks and second abortion of 12 weeks. Her ultrasound, that is TVS done, which shows external uterine fundus flat and with arcuate angle, suggestive of a septate uterus. HSG was also done and which showed a septate uterus. All other routine investigations were normal. So what is your diagnosis and how will you manage it?
Yes, sir. So obviously she's having uterine anomaly, which we usually see in the second trimester abortions, and which in this patient is she's having the second trimester abortions, mostly 14 and 12 weeks. That is the early second trimester abortion. So if everything is normal, there is no other cause, then we can say that the septum is the cause. And secondly, I mean to say, whenever we encounter any Mullerian anomaly or uterine anomalies, then we have to look for the cervix and the internal os as well, because a functional internal cervical incompetence, right? So a functional and a structural cervical importance, these are the two entities. Even though the cervical length is normal, we many a time see that the patient, they have a second trimester abortion or they go into preterm labor. So I mean to say, the functional part of the cervical internal os should be taken into consideration while we are dealing with these patients.
So,
hello.
Hello.
Yes, sir. So a complete hysteroscopic evaluation of the patient will help us in knowing the type of the septum she's having. And if it is interfering, then we have to do the septal dissection as well in this patient.
Yeah, which are the other anomalies you can think of in evaluation? Hysteroscopy will guide us.
We can have a small uterine cavity.
Yeah.
Biconvex uterus, but
I read, can I answer something?
Yes,
I read interesting facts about uterine anomalies. These are recanalization defects. Septum is a recanalization defect, and bicornuate and diadelphys are fusion defects. So what happens is, in a diadelphys uterus, earlier it was an earlier anomaly in arcuate uterus, there is no actually relation with pregnancy losses. The biggest correlation between pregnancy loss is with septate uterus and with biconvex uterus. So these both have to be treated, and the septum is naturally the easiest to treat. But now there is a big controversy in ART because so many full-term pregnancies have been delivered where septum was there. So now there is a controversy whether to operate on a septum or not, but definitely the patient with RPL, we have to tackle the septum and the results are good.
Yeah, but madam, these are only a handful cases where you can say that it is not recommended, but all of us were doing the septoplasty, and this issue also guidelines said that if the septum is there, you have to get rid of that septum.
I think the controversy was created because of some RIF cases, recurrent implantation failure and all. So they started doing some studies that why should we remove the septum. So I think there are some interesting papers. I will share whenever I get time. But in the ART conferences, if sir you are attending, there is a lot of controversy about septum, but people are not following that. People are removing the septum whenever they see it.
Yes. So this is the case I did a few years back, and this is you can see the laparoscopic one fundus is there. There is a intravaginal septum is also there. The two cervices are there, and a big septum is there. So if the thick septum is there, which method you will go for the septoplasty? Dr. Manisha?
Yes, sir.
Which method you will go for this? Whether you use scissors or you will use current?
Either can be used, sir. Either resection with the septum or cautery can be used to remove the septum. I mean, the histoscopic personnel will decide depending on the maybe size of the septum or convenient, I guess.
Whenever it's a thick and a flexible sort of septum, I prefer using cold scissors. It is easy. It is non-traumatic. It doesn't bleed. But where the septum is thick, then I prefer to use a current. It is very easy. You can decide. Again, if you use a current and after that you give 2 or 3 cycles of HRT to the patient, the endometrium forms well.
Yes.
So yes, sir. So I think we can safely use the current with expert hands.
Okay. So whether you go for the septoplasty with the current or these scissors, the live birth rate is same, equal, and it's just a matter of months. And when did you start this getting induction of the patient for this pregnancy? When did you allow that patient to get pregnant after septoplasty?
Sir, after septoplasty, immediately on day 2, day 3, I start estrogen tablets.
Yes.
And whenever I plan a withdrawal, I give 5 days of progesterone, either medroxyprogesterone acetate or norethisterone. And once the patient gets the withdrawal, and she is forming a good, sort of 3 or 4 endometrium starts forming, I start to give her ovulation induction if she is also an ovulatory factor.
So
Otherwise,
just after next cycle.
Next cycle, but otherwise they recommend 2-3 cycles of HRT, but I don't wait that long. In private practice, we start in the next cycle or next to next cycle.
Perfect.
Yeah.
So what other uterine pathology you are suspecting, Dr. Purnima?
Sir, among the uterine pathologies, there can be any space occupying lesions such as fibroids, polyps, or they can be like adhesions in the uterine cavity, also Asherman syndromes. These are the anatomical factors. They can be functional factors also, like which can lead to dysfunctional endometrial factors also, like thin endometrium, poor vascularity of endometrium, or chronic endometritis, as we have already seen in the last lectures. So these are the uterine factors which can lead to RPL.
So which polyp you will remove?
So we would remove the submucosal polyp or the submucosal polyp, and the intra-neural polyp also, which is actually distorting the cavity and indenting the endometrium.
Sir, if I'm introducing the hysteroscope, I will remove every polyp. Okay. Unless they are very small. If I'm introducing a scope, and if the polyp is accessible, I will remove it.
Yes, sir. There is no point in keeping the polyp there.
Polyp should be removed because I thought, yes, the fibroid, submucous fibroid, and the intramural fibroid, which is indenting the cavity, should be removed.
That is
They said that if the fibroid is polyp is of size 1 millimeter, 1 centimeter, then you can also keep this, and then live birth rate is also equal. But then no one will keep this in the uterine cavity if you are doing the sopping.
And we will remove it. Yes.
Yeah. So something about the infection. So this is the video which shows. Just look at this video. Dr. Monica?
Yes, sir.
So what are your clinical findings on this hysteroscopy?
So when we nowadays we are doing the vaginoscopic approach for hysteroscopy. We are doing vaginoscopic approach for everything. So we wait at the internal os. We let the fluid go inside, and definitely in a case of chronic endometritis, you might find some chronic cervicitis also. The normal cervical mucosa, which appear very nicely, they might be disturbed. And in these cases, there are some micropolyps. The pathognomonic feature of chronic endometritis might be micropolyps, very small, small. And when it is a chronic infection, then the endometrium appears flattened. It might show these flimsy adhesion bands. And in long standing cases, the flimsy adhesion bands can give rise to fibrous strands. If there is superimposed tubercular infection, there is a typical picture of Cox endometritis. This is a good time to take an endometrial biopsy for your tubercular mycobacterium analysis, and send it in 3-4 samples. Purnima, what are the 4 tubes in which you sent? We did it.
Ma'am, first is for histopathological analysis, then for culture, then CBNet, and then for microscopy, plain microscopy for ZN state.
Yeah, Dr. Sandeep, we keep revising this.
Yeah, perfect answer.
So she only taught me because she did some good cases in AIMS. So she only told me. So we are doing this. So these are the and sometimes the ostia of these uteri might be having flimsy adhesions. The ostia might not appear, good, and the fish mouth appearance of the ostia is also lost in chronic endometritis, sir.
So, Dr. Purnima, how will you treat this patient?
So the doxycycline 100 mg BD for 14 days is the simple treatment because the most common organism is chlamydia, gonorrhea. And, if mycobacteria is detected, then of course the antitubercular therapy is there.
Is there any treatment other than this antibiotic?
There is ciprofloxacin and metronidazole for 14 days, but doxycycline, we generally give doxycycline.
Yeah, right. Can we give this probiotics?
Yes.
Yes, we can give probiotics, sir.
Yes.
So which probiotics is preferred?
Sir, I think we should give probiotics to these patients.
So which type of oral intake probiotics or vaginal probiotics you will give?
We are giving
oral probiotics.
Because there are these prebiotics and probiotics. So once the patient takes it through her gut, it will go into her fecal route, and from the fecal route it will enter into the vaginal route. So that is prebiotic and probiotic. Both of them should be given in combination for optimal. It does have an effect.
Yeah, but perfect one. But this recent study showed that if we give the probiotics which are vaginally active, then vaginally prescribed, then they give the maximum positive impact on the endometrium, and we give the positive impact on the implantation also, and for the further management of the pregnancy also.
So what are the vaginal probiotics which you are using?
I know only one brand, but I can't take on this platform.
Yes. So you can put in the chat box.
Yes, definitely, madam. Definitely, madam. Yeah.
So yes, because it's useful tip.
Yeah, definitely. So coming on to our third case, we will take Dr. Rujita.
Yes, sir. So she's a 22-year-old and she's gravida 3, abortion 1, and 7 months pregnancy, presented with chronic headache since the past 15 days. Okay, she has been diagnosed with high blood pressure since the same time. And she's having first spontaneous abortion at the 6 weeks, and for that DNC was done 1.5 years back, and the second is 27 weeks IUD 1 year back. And her blood pressure is 140/100 and pulse is 92. Fundus examination was normal. Per abdominal examination corresponded to 25 weeks of gestation with mild IUGR. And the CBC, KFT, LFT, USG is a normal. Thrombophilia profile is done, and lupus antibody, anti-cardiolipin antibody, and dsDNA antibodies were strongly positive. So clearly, this patient is having a bad obstetric history. That is, and now she had previous one abortion and IUD. So that points towards the some immunological factors that is operating here, and mostly the autoimmune conditions which we have thrombophilia hereditary as well as the acquired thrombophilias. So, and that turn out to be strongly positive. So she's a case of thrombophilias, lupus antibodies.
Yeah.
Right.
So, Dr.
DSDNA
Monica.
is strongly suggestive of systemic lupus erythematosus. So DSDNA is very specific for SLE, and her history also points towards the SLE. And she has a chronic hypertension, and that means even she has a renal involvement as well. So though we are having fundus examination, which is normal. So this is a very crucial period for her. She had her IUD at the same gestational age in the previous pregnancy. So we have to be very careful now, and we have to do all the investigations and evaluation of the mother as well as the fetus. Mother, obviously serial monitoring of KFT, urine output, blood pressure, and the development of superimposed preeclampsia and eclampsia. And at the same time, the fetus also needs evaluation in the form of fetal 2D echo, because congenital heart blocks are very common in the SLE patients, and unexplained fetal loss at term is also very common in the SLE patients. So we need to evaluate the fetus as well in this.
Perfect. So we are dealing with this primary antiphospholipid antibody syndrome. So what are the diagnostic criteria for Apla's syndrome, Dr. Purnima? Is there? Dr. Mayuri?
There are blood investigations.
Hello.
Hello, am I audible?
Yeah.
Dr. Mayuri?
Is there are blood investigations which can be done. So they have to be done twice, 12 weeks apart. IgG, IgM, APLA antibodies, and micro 2 globulin, anti-micro 2 globulins.
Right. So this there are two methods, that is Sydney class consensus on the classification of APS syndrome, and another is this Euler classification. Euler classification 2020. This is the recent classification. So coming on to the main criteria, that is clinical criteria that Rujita already pointed out. So there may be the evidence of arterial thrombosis or venous thrombosis. Like in this patient, she was having headache, and then there is repeated fetal loss before 10 weeks or unexplained after 10 weeks. So these are the few clinical criteria. And what are the laboratory criteria? This Dr. Monica?
Laboratory criteria are detection of the lupus anticoagulant, which is the strongest marker, anti-cardiolipin antibodies, which is the second strongest marker, and anti-beta T2 glycoprotein antibody, which is under review nowadays. It is not very commonly tested. So lupus anticoagulant should be measured 6 weeks after the previous pregnancy loss, before the patient conceives, on 2 separate occasions, at least 12 weeks apart. And anti-cardiolipin antibody, the titer should be more than the 99th percentile. You can measure IgG and IgM. Again, 2 different occasions, at least 12 weeks apart. And anti-beta-2 glycoprotein antibody is not very commonly done in the labs. It is still a research test, sir.
So if the patient aborted right now, today, and then we have to test her for Apla syndrome, then we have to do this after the 6 weeks, right?
After 6 weeks.
Yeah, and the next test will be on after the
12 weeks.
Will be from that day.
Yes.
Right. Perfect one. So we will not go into the theoretical this and the mechanism of Apla. So what is the symptomatology and how will you manage the obstetric APS? Dr. Manisha?
The symptoms, as already told, the patient will have high blood pressure, and hence she will complain of headache. And DVT is the most common symptom in this, and which accounts for around 30 to 55%, and almost 50% of the patient will have arterial occlusion, and the brain is the most common site which will cause it and causing headache in these patients. Also, thrombocytopenia and hemolytic anemia will be the presenting feature in this, and that may lead to IUD and hence severe IUGR and toxemia of pregnancy, which is already given here.
Right. So how will you manage this patient, Dr. Monica?
Uh, I don't. I'm not very obstetric person, but still I will try. I think somebody else can take this who is doing
Yeah,
active
yeah,
obstetrics
Dr.
here.
Meena.
Manisha or
Yes, we have to monitor in
Anybody can.
yes.
we have to monitor in labor and this thing labor and preparing. We have to keep the close contact. When she goes in labor, we have to monitor strictly like eclampsia and pH, whatever we think. Regular BP monitoring, regular premotor symptoms. We have to explain the patient when we go for the ANC follow-up about the symptoms of PIH and all. And then we have to go for strict follow-up and blood investigations regarding HELP syndrome and this thing.
Yeah, even antenatal period, we have to give her aspirin as well as low dose heparin.
Yeah, what I wanted to point out was when there was history of spontaneous abortion in earlier, and then there was IUD at 26 weeks. The but I mean, she could have been started on the aspirin as soon as her UPT was positive. Maybe that would have prevented the
Yeah.
further complications.
At least from 12 weeks, we conventionally say that the aspirin should
Yeah, but
be
the
started.
presentation starts by if there is any abnormality, you can start it directly after you get UPT positive, so that at least there is some effect of that aspect. And then heparin is something different, which is, I mean, IVFs go for the ART consultants are all for heparin and all, but we don't usually start with heparin directly.
We also don't start. I also don't prefer heparin, even in my ART cases, unless it is a proven history of first trimester loss or proven APLA. Heparin makes a very small part, but low dose aspirin I like. Low dose aspirin.
What do you use? Have you started using 150 or 75?
75.
75, but as soon as the patient conceives, I switch to 150.
150. Because recently they've come up with the guideline that you should start with 150.
Yeah, but in ART cycle, I use 75. And that also we have to keep a close watch for gastritis and everything. I had a case of gastric bleed with 75 ecosprin, but that was at 24 weeks of gestation. So patient had to be completely stopped with, and she continued pregnancy nicely. So HDP also, and HDP prophylaxis also says that 75 or 150 ecosprin, the choice is 150, but don't use it as a blanket cover.
Yeah.
Use it where there are HDP risk factors, or in this APLA risk factors. Yeah.
So what dose we should use? Like,
what I want to
what
say
will be
is,
the
if there
message
is
to the
APLA,
audience?
diagnosed APLA, then it's better to start her on heparin.
Yes, definitely. If it is diagnosed APLA, then no doubt we have to start on low molecular weight heparin. Yes.
So, Dr. Monica, will you start this aspirin also and heparin also?
Yes. Improve an APLA.
Yeah, because the action of both of them is different, right? I mean, the pathway where they act is different. Right? One is balancing the prostaglandin and prostacyclin pathway, and other is totally going for these what we say extrinsic and dealing with the extrinsic and the intrinsic pathway. So this is different.
Yes.
Right. So the evidence said that if you start this low dose aspirin, that is maybe 75 or 100 milligram, and associated with this low molecular weight heparin, starting from the 40 milligram dose or 1 milligram per kg dose, then we can get the better live birth rate compared to individual drug. So it is better to use the two drugs simultaneously.
Yes.
Yeah. Now this patient, we carried forward with this patient till the term, and at around 37 weeks, she came in your casualty with labor pain. What questions you will ask Dr. Monica to her pertaining to the low molecular weight heparin, and what will be your management during the labor?
Ecosprin and heparin we have to stop before terminating the pregnancy, whether it is a normal delivery or a C-section, and we usually stop 24 hours prior to the induction or the labor, whatever, and monitor with the help of the coagulation tests APTT and the prothrombin profile. And we also keep in touch with our, the anesthetist. We inform about this, about the patient's drug history. And then post delivery also we monitor the coagulation profile. We keep the patient under watch, and we also inform the neonatologist about this, especially if it is
you are thinking of pertaining to the questions to the anesthetist.
Suppose it is a C-section and the patient has been taking heparin in the last 24 hours. The last dose was taken 36 or 24 hours prior to the C-section. The anesthetist has to be informed. And just you have to be careful about the uterotonics and anticipate PPH or anything like that. But usually it doesn't happen. If you stop,
anesthetists are worried about this, bleeding at the site of this spinal anesthesia.
Yes, anesthetists are basically worried about the prolongation of surgery.
Right.
They are always asking kitna time lagega types, na? So.
And once that cesarean section is over, then when will you start this heparin again?
I think within 6 hours we should start heparin.
Pardon?
Within 6 hours, sir.
Okay.
We have to start within 6 hours, because most of the thromboembolism they occur within 24 hours of the section or any operative procedures.
Right.
So it's better to start. So 6 to 12 hours interval, I think. After that, we should start heparin again.
Okay. And for how long do you continue with this heparin, this Manisha?
Sir, we'll continue this heparin for almost around 2 weeks to prevent further thromboembolism and DVTs in such patients. We'll ask her to continue to at least 2 weeks.
Guidelines say actually we should continue it up to 6 weeks postpartum.
Perfect.
Okay.
So you have to continue this anticoagulants till the 6 weeks, and if she is having episodes of venous thromboembolism in the past, then we can continue in the after 6 weeks also. But we have to shift from the low molecular weight heparin to the oral component like warfarin. So this part is covered. Now coming on to this next case. So Purnima madam, are we allowing this case time, or time is up? You can continue. Shall we continue?
I think so.
This is the last case.
So you can just summarize, I think, ma'am, summarize the message.
Yes, the last case can be little bit hurry because we are past 7 o'clock. But we can wrap up this case. Sandeep sir, you can wrap it up with your message. Yes.
This is a case of hereditary abortion, one stillbirth, one with 20 weeks pregnancy, and with the bilateral upper extremity swelling with absent fetal movement in 3 days. She had a history of stillbirth of 25 weeks gestation accompanied by eclampsia during that gestation and before her labor induction. And secondly, she had one abortion of 11 weeks gestation. Her endocrine and infection screening were negative, and her blood pressure was 150/94 millimeter mercury. On the blood test, we find out that this ANA was positive and anti-DS DNA was also positive. So, what is your probable diagnosis? So this is a case of autoimmune disease, and mostly they are the SLE or SLE, systemic sclerosis or Sjogren's syndrome. And these are the few medicines which are available, that is aspirin, prednisolone as an anti-inflammatory effect, IVIG, LIT therapy, and plasmapheresis and heparin. Have anyone used IVIG or LIT in such cases? Dr. Monika?
No, sir, I don't use LIT, I don't use immunoglobulins. I do very simple ART. I don't use anything which is not evidence-based. I don't use, sir.
Right. Even this history doesn't advocate the use of IVIG or LIT in such management, and they use this aspirin, prednisolone.
Sir, I do so many studies, even for X-ray, that I really don't feel like using which is not evidence-based, though people have results. but I don't feel I'm doing justice to the patient if the medicine is not carrying the evidence, sir.
Okay. Right.
Yeah.
So, what are the different endocrinological diseases related to RPL, Dr. Manisha?
Sir, it could be hypo or hyperthyroidism. Also, it could be uncontrolled diabetes mellitus, hyperprolactinemia may cause RPL, and uh, other endocrinological disorders like PCOS can cause RPL in such cases.
Right.
Yeah.
So we'll run fast. So ISHRA guidelines states that for the hypothyroidism, we have to test this serum TSH and T4 level along with the thyroid peroxide antibody. Is there any role of vitamin D? Dr. Purnima?
Definitely.
Yes, so there's a role of vitamin D in prevention of RPL, and the dose recommended is prophylactic dose is 2000 IU and the therapeutic dose is 6000 IU.
Dr. Mayuri?
Vitamin D is said to be helpful in PCOS also. And since many patients are not sun exposed, so there is no harm in giving vitamin D. Actually, I don't know the evidence, but I feel there is no harm in giving vitamin D.
Yeah.
Right. So this vitamin D, there are receptors are there in the placenta, and they immunomodulate the conditions. If there is impaired cellular immune system, then this vitamin D helps in increasing the NK cells and NK cell toxicity and higher TH1 and TH2
Nowadays,
ratio.
this high dose vitamin D3 has come up as a treatment for all the inflammatory and autoimmune conditions.
Yeah, high dose means what, Vijita?
Sir, once a week we can give 60,000 IUs of the vitamin D3.
Yeah, but then the study shows that if you give this high dose of vitamin D, that is 60 K per week, then this may have anti-estrogenic effect on the endometrium, and this will prevent the implantation. So better to use the daily dosing rather than giving the weekly dosing in such patients. If the patient, if you did the vitamin D, if you did the vitamin D evaluation, biochemical evaluation, and if it is below the critical level, then you can go for the therapeutic doses like you said. But if you are planning for a pregnancy and if the patient is for recurrent pregnancy loss, then don't give this 60 K dosing as suggested by the study. Yeah. Thank you. So we are on the summary of the panel discussion. So these are the different therapeutic interventions for the RPL. This is all we have covered in this. But our topic's name is algorithm, so I have just highlighted all these different therapies available. And this is another slide for this.
Sir, very nice panel you have made.
Yeah.
Congratulations, very nice.
Very good. Good
So I
cases,
think
and
we have covered
everything is
all the points,
covered.
and I would hand over my mic to this Dr. Pragati.
Dr. Pragati is, I think she has left.
I think she left. She had.
Okay.
I
so,
think.
Thank you all the panelists for joining this and giving your input, valuable input, and making this panel discussion interesting.
And very some new points, new inputs, and I heard for the first time many things.
Yes, and all the panelists were wonderful. And thank you so much, Dr. Rujuta, Mayuri, Meena, Manisha, for joining us at such short notice. And
Thank you, madam.
We didn't know each other directly, but now it looks
Thank you so much.
we have a lifelong friendship. So
thank you so much, ma'am, for
Thank
giving the
you so much.
opportunity. Thank you so much.
Sandeep sir, I met for the first time in managing committee Foxy, and we just started, sir, aap panel kar lo. So it was like this.
Yeah, thank you, Monica madam and Purnima madam for giving me this opportunity.
Thank you so much. It was a wonderful webinar, and I'm grateful to all my speakers, the Foxy office bearers, Foxy Endocrinology Committee, and last but not least, our moderators, our chairpersons, and finally, INTAS for giving us the academic platform and the technical support. Thank you, Dr. Vishal Dave from INTAS. Thank you, Team Intas. Thank you, Purnima, for helping me out. Thank you so much. Good night. Good night.
Yeah, bye. Thank you.
Bye. Thank you. Thank you.